have Professor Caroline Buckey, who is a Deputy Director at the Institute for Disease Modeling with the Gates Foundation and a tenured Professor of Epidemiology at the Harvard T.H. Chan School of Public Health. Of course, she's also the co-founder and co-director of Crisis Ready, a data-driven disaster response partnership between Harvard's Data Science Initiative and Direct Relief. Professor Buckey's academic research focuses on developing analytical and data collection tools that support governments and communities to understand and control infectious diseases, with a particular focus on vector-borne diseases and malaria. She also co-leads the Harvard Salate Institute South Asia Climate and Health Research Cluster to measure the impact of extreme heat on working women in the informal sector and to co-design adaptation strategies with women's organizations. Join me in welcoming Professor Caroline Buckey.
Thank you. It's a real pleasure to be here today. I've worked in Guyana with colleagues who are in this room for some time, and it's a pleasure to be back. I love Guyana. And today I want to be very clear, I'm going to be presenting work in my capacity as a professor at Harvard and not in my capacity on behalf of the Gates Foundation. I just joined the Gates Foundation 3 months ago, so I'm worried I'll say the wrong thing, which I probably will. So this is, as a professor, I'm speaking to you, and it's been really nice to hear all the research going on in the Caribbean. So first I want to put my acknowledgements up front. I'm going to present work that has been done here with the VCS, the Ministry of Public Health, Dr. Horace Cox, Reza Niles, Olivia Valls, Kashana James, Olivia Spencer, Wallace Rodriguez in Region 9, as well as colleagues at Harvard. And the modeling work I'm going to present has been done by Emmanuel Dankwa, who is a postdoc at Harvard with me. And before I start, I want to acknowledge and remember Peter Hill, who recently passed away. He was our driver on our many adventures in Region 9. We will miss him very much. And I just want to point out how important drivers, transportation, and implementation in the field really is. We've all been in situations, here's Peter wading into some water to see if we can drive across and fixing the truck. And I think for remote populations, which I'll talk about in a bit, we really need to take into account logistics, because often public health comes down to logistics. Okay, so in general, when we think about surveillance, we have a population like Guyana, and we have a different burden of disease, no matter what it is, in different parts of the country. Countries have to make a decision about resource allocation under budgetary constraints, and the way that they make those decisions is through a surveillance system that provides reports from clinics and hospitals. So in the context of malaria, which is what I will focus on today, but I think it's relevant for other vector-borne diseases in particular, that means getting diagnostics and treatment to the facilities that need them, making sure that there's delivery of insecticide-treated nets, spraying where relevant, as well as potentially environmental modification. So these are multiple commodities that have to be delivered, and what's coming back from the field are data that we perform analytics on to try and understand the situation. And the work that I've done over the last 16 years at Harvard is trying to improve this side of the equation. How do we get better data and analytics to inform the decisions that we have to make? One of the most important pieces of interpreting surveillance data are transmission characteristics and the disease outcomes of the pathogen that you're interested in. And I'm going to focus on infectious disease today. The reason that this is so important is something that I've spent many years studying, which is human mobility and migration. But if you look at the transmission characteristics of a pathogen, you may have some incubation period between becoming infected and showing symptoms. And there's no health-seeking behavior, obviously, that happens in that time period. And then we also have a latent period where you're not yet infectious. And you can have complex relationships between these time periods. And then you have some period where you may have clinical disease or you may not. Now, this incubation period varies a lot between pathogens. And I've just put a selection of incubation periods up here. For SARS, it's 1 to 14 days. Cholera is like 1 to 3 days. Malaria is about a week or two. and HIV is very long, obviously. So what are the implications of these different incubation periods? So in the context of mobility and migration, we have to remember that from surveillance perspective, we only see the reports coming from people who have sought treatment, who have clinical disease mostly, unless we are doing active surveillance. So when we think about how people move around and go about their day, we have commuting, thank you, commuting patterns, social visiting, many complex behavioral dynamics. And then we also have these seasonal and long-range movements that can happen, both international travel, which we know is very important, especially in the Caribbean, but also labor migration, which I'll talk about a lot, seasonal agriculture. Holiday travel is a huge driver of things like flu outbreaks, and so on. The implications are important because they determine the burden of disease spatially and over time. So this is a map of Sierra Leone. We did this study looking at the dynamics of cholera outbreak and an Ebola outbreak in a very similar time period on the same population. The color of the heat map represents the intensity of transmission in those places. And what you can see is that cholera, which has an incubation period of about 1 to 3 days, is focused in the capital and then spread out in a traveling wave-like pattern that was quite predictable. Ebola, on the other hand, has an incubation period of about 10 days. People travel a lot in West Africa. You can get very far in 10 days. And so as a result, Ebola is just inherently less predictable. So this is an example of how transmission dynamics impact our ability to predict what will happen with outbreaks and then allocate resources effectively. In this case, it would be vaccination. The other thing about these incubation periods that are longer, and so malaria is an example of a moderately long incubation period, is that your catchment area is wider. So if we think about a facility reporting at this place marked by an X, we estimate the catchment area maybe within that administrative unit. But then there's probably a larger area across the administrative boundary where people are coming to seek treatment. And if you have a long incubation period, then you may have traveled very far before you start to feel sick and you go and seek treatment. So the true incidence, the true catchment area that you need to consider for a single facility may actually be very large. And that is directly correlated with how long that incubation period is and whether the disease causes clinical symptoms in general. For malaria, this has direct implications for how the control program proceeds. So if you are getting bitten in the forest and then you don't start to feel sick until 2 weeks later, you may have gone home, and then later you start to feel ill, maybe you'll wait a few days and then you go and seek diagnosis and treatment if you do. And if you don't have symptoms, you won't. So for the control program, you have to deliver vector control interventions, and that needs to happen where the infections are happening. You need to make sure that there are diagnostic and treatment facilities available to the places where people, this slideshow wants to go on its own, where people are actually showing up to seek treatment. And then you have home-based, bed net delivery and things like this. So this is quite a complex resource allocation problem. Guyana, as we all know, has very low population density, mostly along the coast. This is just from World Pop, and you can see that the heat map is the population density. It's clustered along the coast. The interior is where most of the malaria cases happen, in the forested areas. And to get there is quite difficult because of the remoteness and the forested environment. So we have small planes and boats, and travel is difficult. And as Dr. James in her talk yesterday described, there's also much gold mining that happens in Guyana. And I'm going to talk about the role of labor migration in transmission of malaria, the role of labor migration in outbreaks, and how that feeds into our ability to do surveillance. So Guyana in the Amazon basin is one of the places where we have both malaria endemicity and gold mining, and this issue of remoteness. So this map is generated using satellite imagery. You can see in gold is where the gold mining regions are, and the gray areas are remote. So these are places where it's very hard to travel. And what you can see, Guyana up in the corner there, we have both overlapping. Purple is where we have both remoteness and mining happening. And that creates challenges for both surveillance and delivery of healthcare. In fact, Guyana and the Guyana Shield is somewhat unique in this respect. If you rank access to clinics in walking distance, so this is how long it takes to walk to the nearest clinic, across all malaria endemic countries that have gold mining, what you can see is that the Guyana Shield region is the most remote. So this represents significant challenges for how you interpret your surveillance data and also how you make sure that there's diagnostic availability, treatment, and so on. So here's a picture of the Guyana Shield, just showing the areas impacted by gold mining and the relationship between the gold price and deforestation. We know that deforestation occurs when people are trying to get to mine. And so what happens is we have this relationship between the international gold price and the yearly deforestation index. The mechanism by which this generates malaria is that forest edges are created when we deforest, and Anopheles mosquitoes that spread malaria are forest edge species. They like the edges. And that's why when you have small patches of deforestation that are often associated with artisanal mining, you actually increase the surface area for Anopheles breeding, and so you get a significant proliferation of anopheline vectors. The mining also leads to degradation of forest environments, which creates ideal habitat for sandflies, and eventually Aedes as well, once there's a built-up area and they get transported, so annoying, on trucks and things like this. So mining and labor migrants that accompany mining and logging and so on have a significant impact on the vector species distribution and habitats that are created. And a study in a study in French Guyana asked miners, gold miners, their main chief complaints that they go and seek health treatment for. And their top three were malaria, leishmaniasis, and dengue or chikungunya. And so these are very critical health outcomes in these regions. In fact, we did a study with Dr. Cox and colleagues here to show that the gold price, the international gold price, was the single best predictor of malaria cases in Guyana, more than rainfall, more than environmental factors, during this time period. And that's through this mechanistic process of creating habitats and then bringing people to the forest to be exposed to them. So if you look at the demographic data on who gets malaria in Guyana, you can see that we have a disproportionate amount of working age men. This is the age and sex breakdown of malaria cases between 2007 and 2019. So you can use routinely collected surveillance data like this to get hints about what's happening with transmission. In fact, I think there's a lot of routinely collected surveillance data that is not being used enough, and we could use to do inference on in a more sophisticated way. If you look at the correlation between the adjusted gold price and the number of monthly cases, and you break it down by men of working age and everybody else, you can see that the strongest correlation is between the gold price and men of working age. So this is a strong hypothesis that gold mining is an important driver. So I think these age distributions, and I should point out that in many countries in Africa, these age categories are not collected routinely. So the Americas has an advantage here because the surveillance system is actually collecting a lot of granular detail. If you compare the Guyana age and sex breakdown with Colombia, for example, and look in subpopulations, you can see what's happening with transmission. In the middle, we have the mining regions in Guyana, the malaria cases, which skew towards working age men. Colombia on the left, you can see this mixed distribution. And if you break that down by region and geography and subpopulation, you can see on the right that in indigenous people in Colombia, we have mostly children getting malaria. So this is a more robust local transmission happening compared to places where labor migrants dominate. So we can use these types of surveillance data to get a picture of what's going on. The other thing that we've used with our colleagues here is the travel history data that is collected routinely with malaria cases. And so in this, on the report form, the patient is asked, where were you 2 weeks before symptoms started? And we know the location of diagnosis. And so if you map out a network that says, what is the relationship between where they were 2 weeks ago and where they have received diagnosis, you see a network like this on the right. So the purple dots are the location of diagnosis, the yellow dots are the location of infection. And what you can see is that we have this broad network where a lot of people are getting diagnosed and treated very far from where they were infected. And in fact, if you map the distance that somebody had traveled to receive that treatment, and you compare it to the closest facility that they could have gone to, you can see a large difference. So here, the purple bars represent where people could have sought treatment, and the green bars represent where they did seek treatment. So you can see in the malaria endemic regions, 1, 7, 8, and 9, people have traveled very far to seek treatment. And this is just from routinely collected data. You can start to build up a picture of what's happening. Oh dear, I'm sorry. Okay, and so what I think is going on here is that you have local communities where you may or may not have that much vectorial capacity for local transmission, but then you have mobility happening on top of it. So we have labor migration happening, and then we have spillover to the local community. And then we have a more local mobility network happening with people living in those villages nearby. And so I think one of the important takeaways here is that our health systems are designed imagining people to be like a series of discrete ponds around an environment, right? We have a census, we think that that's the population at risk, we go and we deliver services accordingly. But in fact, on the right, you have a lovely picture of Guyana. It's the land of many rivers. I think we have to think about our populations as rivers. These are highly mobile populations, and so we're all connected, and that has very important implications for surveillance. And I think the Caribbean is the same. So we definitely have more discrete units with the different islands, but there's a lot of mixing, and so there will be synchronicity of epidemics, surveillance will be a regional issue, and coordination of response will be necessary to prevent outbreaks across the whole region. So just to speak to this regional issue, here, of course, there are important international migration issues happening around mining. And we did a study in Region 9 in the south, and you can see a map there of the main villages, Aishalton and Croda, and the Marudi mine in Region 9 in the south. And when political changes happened in Brazil, we saw Brazilian miners come and move into some parts of Guyana. Now, what's interesting here is that if we just looked at routine surveillance data, we would only see the bottom two rows here in Aishalton village and Crodar village, and we would ask, why was there an outbreak of falciparum malaria in this time? But the changes in the mining mean that we have to start doing surveillance in the regions where people are actually mining. So this implies that we need to put surveillance and treatment into the mine to stop spillover from happening. And Dr. James nicely described how that worked for this pilot, where we had mapping of local and imported cases, and we had strong community engagement to make sure that people returning from the mine were getting screened and treated, and we did active case detection in their households. So similar types of dynamics happen across the region. This is the Colombian-Venezuelan border, where we had a large influx of Venezuelans following the political crisis there. The pink is the migrants coming into Colombia, to one small region of Colombia in the north. The gray are the malaria cases that arise immediately after that. In the bottom graph, you see Guainía, which is across the border from the Yapacana mine, which is one of the largest gold mines in Venezuela, actually in the whole region. And what you can see is these stochastic peaks of transmission. The dotted red line there is when there was a large flood that washed out all the breeding sites, and then we had a combination of poor surveillance during that time, and probably the breeding sites were washed away. The point I want to make here is that often it's very hard to predict when you're in a regime of stochastic outbreaks, because these are not going to be predicted by long-scale weather or climate. They're going to be sudden shocks that impact transmission very suddenly, and they're largely political, social, and economic. So this was a study done by Marcia Castro's group at Harvard on the left, just showing the relationship between deforestation, malaria under different political regimes. And you can see that the relationship is very tight between deforestation and malaria, but you have, under Lula, the malaria cases dropped, and then we have these dynamics, and the same with the gold price in Guyana. Okay, So I think there's something important here to do with how we address migration and mobility. We have our traditional health system in domain one, where we intervene in these normal traditional ways, but then we have populations that fall somehow outside the health system for multiple reasons. And then we have the interface between those two. And we can design interventions across these different domains. So I'll finally get to mathematical modeling now. I want to describe a model that tries to address this issue. So the Ross-McDonald model is the kind of archetypal workhorse of malaria transmission modeling. It divides up the population into susceptible and infected, and this can be elaborated on in many, many ways. The key insights from this original model were that the incubation period in the mosquito is a key factor, and that the biting rate is a key parameter to act on. And that really informed how we went about the first eradication program. And then for a spatial model, we just elaborate that out into a network. So we developed a model where we looked at how migration might be impacting spillover in different communities. And what we found, so under exactly the same transmission setting, if you increase connectivity between different populations within a network, you get increased transmission, even if everything else is exactly the same. Essentially, you're increasing the effective population size that's susceptible. But if you have a small delay in test and treat in one population that's highly connected to the rest, you have a disproportionate increase in malaria incidence. And I think this will hold in other settings too, and for dengue and things like that. So we normally think about, okay, we need to reduce time to treatment within the health system, but we need to start to develop interventions that are tailored to some of these other populations, and especially at the interface. And that's really what this Region 9 Elimination Initiative is about, trying to develop these interface interventions and put diagnostics in the mind. Okay, so we've done some modeling to show that essentially if you don't address populations that are at the interface here, then you can't eliminate. And the longer the delay to treatment for malaria especially, the more important these outside of the health system populations are. So I think of the Caribbean as a similar network metapopulation. It's highly connected. The populations are small, so what that means is that you're likely to be in a stochastic regime within one island, but as a whole, you may not be in a stochastic regime. You may be in a more deterministic regime. And so what that means is that you need to have, I think you need to have coordination of surveillance, because it should be treated mathematically at least as one connected population. And that will inform both how you do your surveillance, but also what kind of response you need to roll out. And so the bottom line is that if you have coordinated surveillance, then you both understand your system more because you're getting a more holistic readout of the overall population, but you can also detect and manage outbreaks more effectively. I'm just going to say one thing about mathematical modeling. There is a lot out there that makes very big claims with very complicated models. And you'll notice that the model I presented was very, very simple. And I want to just compare this to these two pancake making machines here. On the left, we have a pancake making machine that is very simple, but you can tell exactly how it works. You know which wheel goes round and how it works. And then on the right, we have this rotimatic machine, which can make, it's very powerful and it can make lots of pancakes, but you have no idea how it works. And if it breaks, you don't know why, and you don't know how to fix it. In my opinion, this is the world of mathematical modeling for infectious diseases right now. And my concern is that with AI, we're going to get more and more and more rotimatics, and we'll have less insight by the program on why something is happening. And if you don't understand why something is happening, then you can't develop sensible interventions. And so I like to think of these large, complicated models that look beautiful and they're very compelling and they're often in high-impact journals, but they're like a video game. And if you can't understand them as a national control program, then you definitely can't intervene effectively. And they suffer from this thing of the authority of the inscrutable, which means that they look really good. And if you want a mathematical modeler, maybe you don't know how to interrogate and push back. Okay, so I'll finish. I think in general, we live in a very mobile world. We've done a lot of mobility studies everywhere in the world, and everywhere we expect less mobility than is actually happening. There's a lot of mobility happening. For regions that are governed by stochastic outbreak dynamics, and I would classify the whole Caribbean region that way, long incubation period pathogens are especially hard to predict, and exogenous factors can play an outsized role. So large, weather events and things like this, and geopolitical situations. And so what that means is that interventions need rapid integrated surveillance. And at the moment, I think one of our challenges is data management, basic architecture, digitization, and these things are not sexy, but they are really foundational, and you can't layer on top AI or some of these other innovations, which I do think have promise, but first you need to have this foundational data sets. I'm happy to talk about genomics if people want to. I've done a lot of work on molecular surveillance, but apparently my time is up. So thank you very much for having me, and I'll take questions.
Thank you very much, Professor Bucky. That was well received. The floor is now open for questions. Kindly.
Hi, thank you so much for that amazing talk. Just quickly, I'm Ishan. I'm a medical trainee and public health student from the London School of Tropical Medicine. So the epidemiology is right on my street. But I just wanted to ask, because I've done a little bit of work in Colombia with health access for refugees. You did a great piece there about comparing mining regions in Colombia about with the McDonald model. But have you looked at how changes in the law around health access may have changed those dynamics? Because I know in Colombia, the temporary protection status that allowed refugees to access healthcare may have changed how that care seeking behavior and therefore the models. So I just wanted to ask if that has been done.
Yeah, so local changes are absolutely critical and are likely to have more impact than anything that you can estimate from afar with satellites and various things, right? And yeah, I mean, we're actively working in Colombia since Trump came in. Actually, the Venezuelan migration across Darien has basically stopped. So that means that malaria has come down a lot. But in Colombia, in the north of Colombia, they're still struggling. What I would say is that's exactly why we need local contextual knowledge, because often it's policy changes that are driving transmission and not other factors. And so again, this is another reason why if somebody presents a model that says, we've modeled all the things, and it's, if you don't know which part of the data might be wrong and why, then it's hard to interpret. But basically, yeah, it's a very volatile situation in northern Colombia right now.
Other questions? Interventions?
Not a question, just a comment. Good to see that you're using surveillance data, especially all those fantabulous maps that Guyana has been making about mobility and the data that they've been collecting. And on a lighter note, rotis over here are national food. Let's say rotis and not pancakes.
One thing to say about the Caribbean is that presumably there's good connectivity data from, maybe not, but there's flight data, there's marine traffic data. So I think it would be possible to make a sort of plan based on a connected network approach for surveillance.
Very good. Perhaps a last question, comment, if any.
Just to follow up, thank you for your excellent presentation. Really enjoyed that. Although I know very little about infectious disease epidemiology, quite fascinating what you can do, and certainly applies to other areas. But if there's a situation where the surveillance across, we're going to now look at the Caribbean as your sort of soup that you're going to investigate. If the surveillance is non-existent or minimal in different countries, how do you ramp that up so that the model can actually predict properly what's going on? If you only know one bit of the model, like the migration patterns and so on, doesn't that, and of course we don't have really good, even if we have good surveillance, we don't really have good electronic health record systems to capture cases and so on. And so there's always going to be some type 1 error in terms of
Yeah.
where you get.
Yeah, so it depends because I think in some cases you have a sufficient network coverage that you can infer for populations that you don't necessarily know. You could also think about using proxy variables that are tightly correlated in some places, make some assumptions, and then you'll have uncertainty anyway, right? Because all models are kind of highly uncertain. But I think, with paper-based reporting, you have to, my feeling is that with the push for digitization needs to start at the healthcare worker level, where like, what are the absolute minimum things that need to be digital? And then we can't have them also filling in 3 sets of paper records as well as trying to manage an iPad. And so it has to be done very coordinated and top down so that it's kind of done quickly. As far as blind spots, it's always a problem. Modeling can help sometimes, but it does come with uncertainty. And I think you could be smart about things like wastewater surveillance and things like that. So you could have a sentinel site approach, and there are workarounds.
Very good. Thank you, Professor Bucky. At this time, we'll call on Dr. Narang Singh to deliver the next presentation, which is on recent healthcare innovations in Guyana. And important to note, Dr. Narang Singh has over 35 years of professional experience working with the Ministry of Health Guyana, and of course has been Chief Medical Officer for the past 5 years. He is trained in obstetrics and gynecology and also in public health. And prior to assuming the role of Chief Medical Officer, he would have served also in the capacity of Director Regional Services as well as Regional Health Officer, Region 1. Dr. Narang Singh.
Good morning, everyone, colleagues, distinguished guests, and partners in health. It's really an honor to present here this morning at this 70th conference, CARPHA conference, that is being held here in Guyana. And it's not a research paper actually per se, but just to bring you up to date on some of the innovations in health that we are actually doing that is happening in Guyana. We know that we want to achieve universal health care by 2030, and we are on that trajectory. But as Professor Carling just showed you that about 85% of our population lives on the coastland, and about 15% of the population is scattered in the rest of the country in the hinterland regions and in small pockets. And having access to healthcare in those regions are sometimes difficult, given you see the presentation before, how sometimes it's difficult, the remoteness, getting access by road, even by air, sometimes only by boat, or sometimes only by air you can access some of those communities. And so delivering healthcare in those regions is usually difficult, and that's one of the areas that we, how we can have universal access, but with this geographical challenges you have. First slide. Oh, I can click. All right. Yeah. So Guyana, we are presently we are undergoing a lot of health system and transformation. We are on a trajectory to make Guyana one of the having a world-class health sector. And in order to do this, there's challenges. It's not going to be easy road, but again, we have challenges in human resources, we have challenges in infrastructure, challenges in getting access to those our community. So today I will focus on 4 major innovations. One, the telemedicine platform. 2, the hybrid nursing training program. And a third one, the voucher-based screening program, so HPV and prostate, and also the national school screening program. Good. Keep moving. All right, right. So given Guyana geography, characterized by vast hinterland regions and historically limited access to specialist care, the expansion of telemedicine is addressing this disparity. Because sometimes in some of our most remote villages, it's just a basic healthcare worker that is in those facilities. We have about 405 healthcare facilities in this country. Almost 75% of them are primary care facilities. That's sometimes manned by in some cases, community healthcare worker. And some of these are located in some of the most remote regions, remote areas. And getting access to them, and even for the patients in those areas, getting access to specialist care is sometimes always a difficulty. We'll have to actually bring them to Georgetown or bring them out to some of the more populated regions, which can be very expensive and sometimes time consuming. Sometimes it takes days for them sometimes to actually reach a secondary healthcare facility. So telemedicine in particular evolved from a pilot into a national model of care. Telemedicine service we started this project in July 2023, initially as with 4 pilot sites in the hinterland. These facilities were hooked up with a Starlink connection that is powered by solar, and then you had some internet enabled devices such as you have your blood pressure apparatus, your monitor, and some of the areas we had some more sophisticated one with ultrasound probes, which are hooked up to the unit, and you can telemedicine. These things, and so the telemedicine platform, they are linked to a central location, or to all these sites are actually linked together. And so if there's a need for a specialist consult, the healthcare worker can go on to the telemedicine platform and actually get a consult with a specific physician. If it's an OBGYN or an orthopedic person, they can actually have a live consultation going on, and they could be given advice. If they need to refer the patient, when they refer, we can send in the transportation, we can do an emergency medevac. All depends upon the urgency of the consult. Not only for emergency purposes though, but we are actually doing clinics in some of these areas. Actually, we are doing antenatal clinics with an OBGYN, with a community health worker in one of the remote areas, actually directing the workers to how to check, what to check for, and even using a ultrasound device to actually see the growth and monitoring of the fetus. And it's sometimes amazing to know that some of those things can actually be happening, and we are using the telemedicine platform. Initially, we started with 4 sites. Today, all right. Yes, so we started with 4 sites. Today, we have 150 sites, and it's showed on a map there that where we have these telemedicine sites set up, mainly in the hinterland regions, Region 1, Region 7, Region 8, Region 9, some on the coastlands and some of the rural areas. We are planning to expand to about 200 this year, with 50 more additional sites that will be added to this program. And that will get a big wide coverage of some of the most located remote areas that is in the regions, access to those areas. Because of this, people are having specialized care. We can have teleconsults with psychiatry or psychiatrists. Now we have limited psychiatrists, and we can't place a psychiatrist in every district hospital, but they can do consults on the telemedicine platform. Eye care specialists are actually being done, consultation with retinal cameras. The images are sent down to Georgetown, being read, and a diagnosis can be made. The person probably diagnosed with cataract or even with retinopathy can be recommended to be sent to Georgetown for surgery. We're also doing it in the area of telepathology, teleradiology. We don't have the amount of radiologists to put in every one of the district hospital or facilities where there's an X-ray unit, but we do have X-ray technicians who can just operate the machines. These are digital X-ray machines. Images are created and are uploaded on a PAC system and sent to the radiologist in one of the more higher level facilities, probably in Georgetown or one of the regional hospitals, where they're interpreted by a radiologist who's there, and then they're relayed back to the person, to the worker on the ground. That is helping because sometimes, when they can make a decision where the person needs to be sent for surgery, or they can just put on a simple cast and stay right and be treated right in their community. So telemedicine is really transforming how we are reaching out to our population. This is getting access to more specialized care through a telemedicine platform. So this is something that we think is transforming. It's a model that I think some of our Caribbean neighbors can adopt, especially those that have very small population that is very scattered. Next. Yeah, so the I went through the one for this thing. Our next transformation project that we started is the hybrid nursing program. We know that with healthcare for workforce, in order to expand and decentralize healthcare services, we need a good healthcare workforce, especially in the area of nurses. We know that with the migration, the issue of migration that we are facing, but how do we deal with that? We can't match sometimes the offer these nurses are getting from overseas um, countries. And also, given the expansion and the rapid increase in number of healthcare facilities that we are moving ahead, we'll need to staff these facilities. Prior to 2023, July 2020, we were able, with 3 nursing schools located mainly on the coastline, we were only able to train 200 to 250 nurses per year. This including nursing assistants, midwives, and professional nurses in total. At that time, we had a deficit of 2,558 nurses. It would have took us 10 years to reach that number, given this present output. So we had to do something innovative in terms of nursing training. We, and in July, we launched the hybrid nursing program, which is a combination of a online for the theoretical knowledge, and then we had simulations. So we, in July 2023, we started with the nursing assistant program and the RN program. We started with about 800 nurses in that program. This not only allowed people to be trained right in their community because they remain right in the community. They can go on the online platform, which was facilitated to a Coursera platform, and then they did the theory. And when they need to do this, the practical components, they will go to the district hospital or come to these specific simulation labs that we have built around those areas, and then they can blend the two, blended learning. With this, we've been able to increase the thing by 5-fold, the number of nurses that we've been putting out. July this year, our first batch of RNs will be graduating 685 professional nurses from the first batch of hybrid program, compared to 200 and sometimes 100 nurses we could have put in 1 year, although 200. That is going to make an impact in the nursing program. And we think that this is one of the ways to move forward. Now we have nursing centers, not only in Georgetown, Linden, and New Amsterdam, but we have expanded in Lethem, in Region 1, in Region 7. And so these nurses or the applicants can stay right in the communities and get trained as a nurse and remain there and work. So we know one of the challenges is that when we bring most of our population in the past who accessed the nursing program were mainly from the coastland. And getting them to go into the hinterland region to work in any rural areas is really a challenge. And so that if you come from the area and you train, you're more likely to stay there. And that's how we are overcoming the challenges also. Many times also the cost for sending out a nurse to bring them to Georgetown and facilitating their accommodation for 2 to 3 years was always an expense on the budget to the national level. Now they can stay right at home, be trained in a nurse, graduate, and get job right there in the community. So this is the transformation that we think, that the model that some of our Caribbean neighbors can adopt, because we are all facing the challenge with nursing workforce and how we can deal with the nursing thing. We can't, we can go and hire from some of our programs from some other country, but we'll need to be innovative in how we can deal with the workforce. And this is one innovation that we think is working well, and it's actually making an impact. So let me just a moment. So this is one slide that showed us, the simulation labs that we have set up in several of the regions where the program is being rolled out. So they do the theory online through a Coursera platform, and then when they do practical, they come to the simulation center, they get their practical sessions, and then they continue until they graduate. And the course is so set that they have to finish, it won't allow you to go to do the simulation if you don't pass. Because if you have to complete the course, then it gives you can't move on or you can't move ahead the course unless you finish the exam in the first part. So you have to finish the modules do the exam, then it allows you to get into the second module or the third or fourth modules. You cannot, when the time reach to go to the simulation lab, but then it said you passed it, and then you can go to the simulation lab to do the practical component. So that's how it's been run, and it's not that they can sit down, and then they can do it at their own time too, but they have time limits, right? When you need to complete this module within 4 weeks, but you can do it at your own time, but you need to do it within 4 weeks, and that's how it's being run. And so far, we had 2 batches of one last year. Last year, November, we did one, the biggest batch of nursing assistants, 764 nursing assistants were graduated. And now this in July, we'll be graduating another 685 registered nurses for the first batch from the hybrid nursing program. That's just stats that we're thinking we're there. And you see the nursing training have increased almost no more than 5-fold, almost 10-folds that we'll be putting out through this program. The next innovation that I wanted to share with you is the national school screening program. We know where we look health from childhood on the way to old age. Usually in our system, after 5 years, you start going on the 5 clinics, and after then you'll receive your last growth monitoring, your vaccines. There's a big gap between from 5 years till up to the person reaching adult. There's very little contact points with the healthcare system unless it's an emergency. People, young, they're teenagers, they don't come for routine checkup. And so there's this big gap that is missing. Many of them have disabilities, some issues that are not being diagnosed, and they wait until sometimes they're adult or sometimes in the early teenage, late teenage, then they get access to the healthcare system. The school screening program allows where we are going to the schools and actually taking teams to the schools and screening the children right in the school, within the school compound. Well, with a consent from the parents and so on. So we have started with the nursery, the nursery, then the primary schools, and then now we are in the phase of doing the secondary schools. And the data so far, when they go to the schools, they are actually doing dental screening, they're doing eye screening, they got a hearing test done, they got a physical examination done. If there's need for a specific blood test, that will be requested. And also a mental health examination, screening for any mental health disorders and so on. This information is actually stored in a database so that it will be put in, as we are already rolling out the electronic medical record, which is done at the Chung Hospital. But once it rolls out nationally, that information will go into the EMR, and it will be there. So you can access this information through the childhood. So far, with the screening program, these are the modalities we are actually using. We are going to the nursery, primary school to do hearing tests. The achievement so far, over 18,000 students have been screened in the nursery schools. 68% of the target actually of nursery students who are enrolled in schools. And some findings, we are picking up nursery school students with visual issues. Some of them are having hearing issues. And we sometimes wonder why they're not doing well in school. Some of them had to be given hearing aids. Some of them had to be given spectacles to correct the visual issues and so on. And so these students would have been going to school with this defect and not picked up until later years, until they were probably teenagers, and then we realized that something was wrong, which could have been corrected earlier in life. So with the referral for the nursery, we had, based on the screening we have done, 2.8% of those students we had screened had a visual problem that needs intervention. Dental issues, we see it's a very common problem among the nursery school students. 18.4% of them had to be referred and get dental procedures done. We picked up speech therapy issues with dyslexia and so on in schools. 2.7% of those students actually had a problem with speech issues and actually were referred for speech therapy. And hearing impairment, 9.28% of them had a hearing disability or this issue with hearing. These would have been missed because they had access or they were never brought to the healthcare center facilities to be screened And then they would have gone through their entire primary school, nursery technical school, and then realized now that they were having an issue. So this is some of the data we have. This thing pops. Stick. Oh, yeah. How will we get it? See that? Okay, right. So in terms of the primary school, we have started this primary school starting this year, and so far we have been going into the primary school almost 67, we had here 57,000 primary school students have been screened so far. And this is not only in Georgetown, this is in all the other regions too that have been going. And we've been picking up the same issues, the same challenges we are finding with the nursery school students. We're screening them and we're finding some of the same issues in the primary school students who have been screened. In the secondary school, we recently started this year, and already we have completed most of the coastline areas, and we're moving into some of the hinterland areas, and we are picking up issues. Some that are having mental health issues among the secondary school students, and we are actually providing sexual and reproductive health services to those students who have issues with that we are finding in the secondary school screening. So this is a program that we think it was a gap that exists, and through this school screening program, we are able to bridge that gap and get them into the healthcare system. Because other than that, they would have been just being there, walking around with these defects, sight, visual effects, hearing impairment, dental issues that were not being corrected. And through the school screening program, we are able to reach out to them. And so I think this is innovative. This is one way how we can reach out to our that population that was never really being able to access healthcare. Another innovation that we did back in 2024 was the voucher program. We introduced some voucher in collaboration with the private sector. We had vouchers for what we call the HPV. HPV screening test. This is the one screening test we do for cervical cancer. I mean, you know that cervical cancer is the #1 cancer among women in Guyana. We have a high burden of cervical cancer. Other than vaccination, which we have been doing, which we started doing vaccination, we also wanted to do the screening. The screening test, recognized screening test is the HPV test. So prior to this, we only had 1 or 2 labs that were actually, one lab in the public sector were actually doing HPV screening, which is at the national lab at the Georgetown Hospital. And samples had to be sent, or you had to send a patient to come to get the HPV test done. It was done in the private sector, but the cost of, at that time, some of the private labs were charging $15,000 to $20,000 for a HPV test. We had a partnership with some of the private labs, and they all agreed that, well, we'll issue a voucher to the tune of $8,000. And they can go to any one of the labs that were participating in this program and get a HPV test done. Information is shared with the ministry, and then those who are positive, then we're putting into care and follow up. From this program, and well, prior to this launching this program, HPV testing was almost, in a year, we had 50 to 100 people just getting an HPV test done through our system. Those who access the private care, but we were now aware of them. Now with the HPV screening program, we are able to get more women to be screened for HPV, because we want to achieve the 90, 70, 90 goal by 2030. And with this, we are able to screen over, we have about this, based on our estimate, we have about 200,000 women who need to be screened, because based on the age group, between the age of 21 to 65, who we are targeting to be screened. And so the impact with this, we see that over 200,000 women have already we need to expand the programs. And so far, I think we had over 78,000 women have been screened with the HPV testing. And those results are now available. We see the 16.78% have actually showed up a positive test, and they are being enrolled into the program, right? And now because they will need secondary long-term follow-up to follow them and see if they're actually progressing or not. But otherwise, without this program, we they would have just been there, and then next thing you know, we will see them 10, 15 years down the line with advanced cervical cancer. So this is making an impact because this is the burden we wanted to get rid of. And through this innovative collaboration with the private sector, we are able to get women to come to be screened for HPV and then get them into treatment care once they are positive. So in conclusion, we think innovation, these recent innovation has demonstrated how strategic policy, technology, and partnership can transform our health system. From telemedicine network to preventive screening programs, the country have expanded access, improving outcomes, and building resilience. These initiatives are not isolated. They form a cohesive, forward-looking health strategy that aligns with regional and global goals. So today, I just wanted to share this. So the future of healthcare in our region lies in integration, innovation, and inclusivity. And Guyana is showing us what the future can look like. So this is just a glimpse of what we are doing in terms of innovation. It doesn't have to be technology related, but just simple change in our policy or how we adjust the health system. We can make changes and achieve our goals too that we all wanted. Thank you.
Thank you very much, Dr. Narang Singh. We now welcome interventions from the floor.
Good morning. I really want to thank you, CMO, for your presentation. And, Guyana is really showing some marvelous innovations. And I'm particularly interested in the telemedicine because you're able to reach areas that are not easily accessible for medical care and for health care. And in the Caribbean, I think this could be something that we can really learn from and that we're able to do in countries, especially like, countries like Belize or other areas where it's really hard to reach and you can't easily, just take a taxi and get onto to a health center within 20 and 30 minutes. So I really want to applaud Guyana for the innovations in health, and I'm hoping that, some of these can be transferred. I went to the booth and I really like also the vouchers because, we always have to remember, in every population that you have those who can afford and those who cannot afford. And so what the vouchers really makes healthcare affordable and accessible, being able to do, HPV, being able to do eye testing, dentistry, and all of that. And I really thank that. And it's something I think that we can, that our other Caribbean countries can also adopt because it allows for persons who cannot afford, but it gives them a chance to be able to get the health care that they need. So thank you very much.
Thanks, Dr. Larry.
Thank you. Colleague across the floor, please. Thanks.
Thank you very much. It's very helpful. It's very heartening to see the changes that have already been put into place. And relating specifically to the vision and the activities around young people, that I think aligns quite nicely with the vision that was laid out by the president as well in relation to education and looking after a younger generation. The question I have is how are you sort of aligning closely with the Ministry of Education, both in terms of following up, because identifying those issues early in young children and secondary school students would impact on their learning and the outcomes thereof. So I'm wondering how you're following through with that and also linking that to the education within the community, whether it's the community as a whole or whether it's within the school community to educate our children at a very young age in relation to these healthcare aspects.
with the school training program, we are working closely together with Ministry of Education because to get into the schools, we had to collaborate with the Ministry of Education, so they're well aware. And so they are working along with us. We had the teachers, and they are helping us with the consent, we're getting the consent and the message on. And then we go into the school, we are able to access the students. As you see, when we started the secondary school program, we had to do the amount of testing that we would do would increase because we start taking mental health counselors. That we were finding some of the students were having mental health issues, some of them anxiety, some of them have were using use of drugs and so on, and they are referred into the system, and they're linked to the healthcare system. We haven't done any impact as yet, any impact assessment in terms of how it's impact on the education and so on, because it's only 2 years the program started, less than 2 years it started. But we know we are picking up medical conditions that are being treated and then they're there. So maybe another study is to look back at the impact of these students, how they perform after they were picked up with the eye condition or whether who was given a hearing aid, how they did well in school and so on. So that is something down the line, but so far we are finding issues and then we are treating them, and I'm sure it would probably have some impact in their lives later down in the line.
We'll take the last intervention.
Thank you very much, Mr. Chair. First of all, congratulations, Edwin Belastig, Sub-Regional HRH Advisor from the Pan American Health Organization based in Barbados. First of all, congratulations to Dr. Narayan Singh for his wonderful presentation. I particularly like how you featured innovations in each of the building blocks of the health system. And and also the kind of scaling up that you're doing. So with regards to that, I really wanted to hear from you how the being a system, how these innovations and different building blocks are actually kind of synergistically helping coming together in terms of really strengthening the health system as a whole. And then also in terms of what would have been the lessons with the nursing, the scaling up of the nursing program. I like how you mentioned the use of partnership and networking in getting all of these innovations in place. And so I think it would be useful for us and the other members and other countries who might be interested in scaling up as well. What would have been the lessons that would have been learned from that journey in scaling up the nursing program? Thank you.
Yes, so this is a share. When we started hybrid program, there was initially some reluctance on the traditional tutors because they were always accustomed to the chalk and the talk old format, and many of them had to adjust. So we had to train them how to and record the entire program was uploaded, but they are the ones who were actually doing the lectures online with them recorded and so on, and that took some arm twisting. You got them say, well, this is where we had to move because we can't have all these people coming to Georgia and in a classroom. Eventually, they caught on and that went ahead. The other challenge was the internet connections in some of the hinterland regions because the students had to be at home. And one of the things that we were able to utilize some of the sites that the telemedicine site. The students would go to the health center or the health post, and they can get connected up and they can do the classes because some of those hinterland don't have the internet connection. Some of them don't even have electricity. So they would come to the health site where the telemedicine site is and do their classes online with the computer there. And then, so that was how it was. But putting in network, yes, will need the interconnection was one of the challenge. But we did have some dropouts. What we need to do, we are now looking back at some of the reasons why they dropped out. I mean, why left, and some of them were saying that they got better job and they want to move on. But we almost have over 85% retention in the program. So you got to graduate the first batch. 85% of who started is going to graduate, and that is a big batch. That's going to really make an impact on the nursing workforce in Guyana.
I did say that would be the last. Is the mic a request to speak? Okay, if it can be concise, I can allow it a very
Yeah.
short
Yeah,
response.
all right.
Thanks.
Thank you very much, Chair. Dr. Naranting, I actually wondered, you spoke about a lot of programs that are being offered, and then you made comments, unlike other presenters, that these can be used by other Caribbean countries. But I wanted to find out, in terms of that concretizing that process, how do we go about making it happen, and who should take the lead so that these things can actually move from offerings to actual implementation to other countries? What would be that, some of those steps you see that would be required to get that happen?
We don't have any, we would willing to share, especially for the nursing program, because it's online, but you have to get the access. So maybe some MOU worked out. We can actually give the entire course, you guys can have it on your place and then show how we will roll it out. It's not a secret. We want to share. So I'll probably talk to you at the end of this, how we can collaborate and, you can implement it, because this is not something that was meant for us. Because we got it from a model that was done in Brazil, and they shared it with us. So through PAHO, through PAHO, we can help, get a similar program done in other countries.
Very good. We've had two enriching feature lectures. Join me in appreciating. Thanking Dr. Caroline Bucky
Thank
and
you.
Dr. Bucky and Dr. Narang Singh. All right, so we transition to the concurrent sessions now, and we'll go immediately into same. And I believe session A remains here, and that'll be on infectious diseases. So inviting the chairs to come up.
And the two chairs are Lucy Verderman.
Yeah.
And myself, I'm Gerard Hutchinson. And the first speaker is already ready. This is Dr. Budram, and she's going to tell us about the implementation of the Caribbean Regional Field Epidemiology and Laboratory Training Program and the lessons learned from that implementation. Dr. Budram.
Thank you. All right, so good morning, colleagues. Well, as the moderator introduced, I'm going to be speaking about the Caribbean Regional Field Epidemiology and Laboratory Training Program and some of the lessons that we've been learning at CARPHA implementing the program over the past 10 years or so. And I seem to be running into the slide advancement issue. Um, Sorry, any assistance, please?
So we can.
It's sorry, it's not working at all.
Same problem, yes.
Mm-mm.
Wait, let me get IT.
Thank you, Gabrielle. It's a good thing I'm not, running after a prize or anything here. Okay, folks, so, right. So getting back to the introduction, I'm sure that we're all well aware of that strong health systems do require a very skilled public health workforce. And over the last few years, especially our last assessment in 2022, 14 of our CARPHA member states using the SPA assessment scheme, they scored themselves in terms of HRH at around 50%, maximum 80% thereabouts. And that indicates to us that there are critical gaps in frontline emergency response skills and also overall surge capacity for the region. Now, field epidemiology training programs build applied epidemiology skills in our public health workers, and we typically focus on outbreak investigation, surveillance analysis, and emergency response. We focus on generating data and specifically to promote that culture of data-driven decision making. Now, in terms of the model of FETP programs, and there are more than 80 across the world right now, some of them are, they just have this advanced program. It's 2 years long, whether full-time or part-time. But in the Caribbean, we have a tiered training scheme, basic, intermediate, and also advanced training in the future. And we decided on that model for us because we realized that our public health workers are at different skill levels. Now, the key difference about a field epidemiology program as opposed to an academic program is that the learning approach is very much focused on a practical learning by doing model. So we spend about 25% of our time in terms of theory or the classroom, but the emphasis is really on our field work component. Now, sometimes you may see me referring to FETP or FELTP. When I say FELTP, it just means we have a very strong lab component in there. Now, the value of FETP programs have been very strongly demonstrated, particularly during, outbreak situations. So the 2014 West Africa Ebola crisis, FETPs were very much important there. And of course, more recently, the COVID-19 pandemic within the Caribbean regions, our fellows very much showed their value. So the key objective here is really to share the best practices and lessons learned over the period of implementation, approximately 10 years of our FETP program in the Caribbean. So first up, the program is coordinated by CARPHA on behalf of our member states. We do have that tiered approach. Right now we have our basic and intermediate training, and advanced is coming up soon in the future. Our curriculum was designed very much with the Caribbean context in mind, our health priorities, and involved seeking advice from our country stakeholders. And the program over the last 10 years or so has been largely funded by donors as well as in-kind contributions from our member states. Originally, we launched back in 2014. Our fellows are nominated on an annual basis by ministries of health, and we do have a mentorship-based training model. So that fieldwork component I spoke about, that is very largely supervised by senior officials within our ministries of health, who of course have great experience to share with our fellows. The fieldwork products that our students produce typically are related to surveillance analysis, outbreak investigations, communication briefs, and also at higher levels, health system evaluations. We conduct training assessments, of course, during the period of implementation, as well as post-training, and as much as 2 years post the cohorts are completed. Now, in terms of uptake by our countries, thus far, 18 of our member states have participated, and to date, we have approximately 480 graduates. Now, you might think that's a little bit small for a 10, 11-year period, but the time intervals for training are a little bit different here. So this is not just a short 1-week exercise. Our basic training takes 3 to 5 months, and our intermediate training can take place anywhere between 9 to 11 months. We have a range of persons participating in these programs. Typically, we have surveillance officers, medical and non-medical. We have nursing officers. We have environmental health officers, very important group there. And more recently, the veterinary officers are taking part. We do have some attrition rates, 10 to 30%, depending on the country. But we'll get into that a little bit later. And I do think Dr. Singh mentioned some of the reasons for that. In terms of, apologies, it's moving too fast now. Right, there we are. In terms of the outcomes and impact of the program, what we have observed both at the national and regional level strengthen the outbreak response and disease surveillance capacities. We've seen improvements in terms of data quality and quantity, leading to great improvements in data-driven decision-making. Our fellows have been contributing to multiple of outbreak disease investigations, ranging from vector, food, waterborne diseases, and also vaccine-preventable diseases as well. And we have seen, very interestingly, some career advancement for some of our fellows, even very senior positions, such as national epidemiologists and chief medical officers. We do have a few challenges. Limited country ownership over the years, but that's largely tied to limited human resource capacity in country. Mentor availability can shift. I'm always hunting for mentors for the program. And then we do have sustainability concerns, but that's linked primarily to financial and human resources as well. In terms of programmatic innovations, one of the key things for us very early on, even though we are a new program compared to others, is that we invested very heavily in online training early on. FETPs traditionally are very much face-to-face classroom-based. So for example, when COVID-19 came about, we were a lot more prepared to advance with our training than other programs. We have a flexible approach to our curriculum updates. We do so on a yearly basis. We've been adopting new surveillance technologies and software for training. And also in terms of our mentorship model, and this is a little bit different for FETP programs, we've been actually partnering with international programs and other mentors who have a greater deal of experience to work with our local mentors to build their skills. So in conclusion, the CRFLTIP has contributed over the years to strengthening our public health workforce capacity in the region. We've been building a network of trained epidemiologists that function not only at the national level, but we've been pushing them to work at the regional level, particularly in terms of surge capacity during outbreak and disaster response. And also, of course, all this works towards pandemic preparedness response and overall regional health security. In terms of future directions, we're very much building up our One Health integration approach, so we've been adapting our curriculum. We ensure that our curriculum is aligned to both international and national workforce strategies. Advanced training is coming up soon, and that's going to be a master's level program. And also, of course, many of the tools probably you've heard being developed by CARPHA, we've been implementing and rolling out, and we'll be doing more of that as we go by. So thank you all very much. I just wanted to give a few acknowledgements, mostly to my Ministry of Health counterparts, our various coordinators, facilitators, and mentors, as well as our fellows. And I also wanted to very much mention our international donors and partners who have contributed greatly over the years, particularly in terms of funding and technical support. Thank you very much.
Thank you for that presentation. And I think we have some time for questions. Are there any questions or comments? Professor Simeon?
Thank you very much. Thank you very much for the presentation, Dr. Boudram. Long time no see.
Same here.
And of course, I'm really pleased to hear that you have 480 graduates, which is excellent, you know, and of course, the plans for the MSc advanced program. That is great. What I wonder though is in terms of the continuing capacity development, is it a one-off training? You mentioned basic and intermediate, but are there refresher courses, for example? I mean, my experience is that, you know, people do a course one time and then they, you know, and then that's it. So what is in place to really ensure what to support the graduates to continue their development?
So thanks for that very much, Dr. Simeon. So post-training, our graduates are enrolled into basically our networking platform. We actually do have an online networking platform, and we try to share continuing professional development opportunities through that. So whether it's CARPHA-based courses or offerings or international webinars, etc., we share that through our networks, and we do monitor the student participation as well. So that's very active.
Thank you very much.
Are there any other questions?
I have a question. You mentioned one of the challenges has been country ownership. And I know that this has been a challenge across FET programs around the world. What are some of the strategies that you guys are looking at to increase or, you know, boost that?
Thanks. So I wasn't able to mention this due to the interests of time. But in terms of the sustainability model for the program, we have been working with our member states very diligently, particularly over the last 2 years. And you noted that the tiered model for training, the basic, intermediate, and hopefully advanced, what we have been doing is a lot of training in terms of the focal points, the mentors, and the trainers within country, particularly since we're going to be launching a new curriculum this year. And in doing so, we've been providing them with the technical capacity for them to actually implement and roll out themselves. So we're hoping, COVID really did slow us quite a bit. That was the initial intention. COVID slowed us down, but we're back on track for hopefully countries implementing the basic training on their own with some technical oversight from CARPHA. Intermediate training will continue to be done at a regional level, and advanced, of course, will also be done at a regional level. So it is coming to come, just taking a little bit of time.
Okay, there are no further questions. Let's thank Dr. Boudram for her presentation.
Our next speaker is Miss Sharon Stevens. Great. So Sharon is an environmental health officer at the Ministry of Health in Barbados, and she's going to be speaking to us about knowledge, attitudes, practices, and perceptions of antimicrobial use in the Barbadian food supply.
Hello, good morning to everyone, ladies and gentlemen. I wanted to begin this morning by asking the question, by a show of hands, how many persons would have heard about antimicrobial resistance? But sitting here for the past 2 days, I think it is safe to say that almost everyone has. So what I'm gonna do is I'm gonna ask you then, how important of an issue do you think antimicrobial resistance is? You can do that quickly by a show of hands. Thank you. So we know antimicrobial resistance, or AMR, this occurs when microorganisms become resistant to the treatment making infections harder to treat. This is not a distant threat. Global estimates project 39 million deaths between 2025 to 2050, and that's roughly 3 deaths per minute. AMR is projected to rival some of the leading causes of death globally if it is left unaddressed. While AMR is often viewed as a clinical or a hospital-based issue, there is an important and often overlooked pathway, and that is the food that we eat. Antimicrobials are widely used in food-producing animals, not only for treatment, but sometimes for prevention as well as growth promotion, thereby creating opportunities for resistant bacteria and residues to enter the food chain. But importantly, this risk is not driven by exposure alone. It is also shaped by what people know, what people believe, as well as what they do. And this is where the human dimension becomes critical. AMR is especially relevant in Barbados because we are a small island developing state, and we rely heavily on imported foods, which adds complexity in terms of monitoring antimicrobial use across supply chains. At the same time, surveillance of antimicrobial use and residues within the food system remains limited. Across the Caribbean, most research has focused on clinical or veterinary perspectives, leaving a significant gap in understanding the role of the general public. In my role as an environmental health officer, I encounter food safety issues daily. And what has become clear is that while the systems and regulations are in place, public behavior plays a key role in determining risk. For example, how consumers select food, interpret labels, and handle food at home can all influence exposure. And this study was therefore conducted to better understand the Barbadian public and how they perceive antimicrobial use in food and how that translates into behavior. The aim of this study was to assess the knowledge, attitudes, practices, and perceptions of the Barbadian public regarding antimicrobial use in the food supply. We therefore examined 4 key areas. We looked at knowledge, and this is where we wanted to know what people understood about antimicrobial use and its associated risks. We looked at attitudes, which were their levels of concern and support for action. Practices, how they purchase, prepare, as well as how they consume the food. And perceptions, we wanted to see persons' views on food safety and antibiotic residues. And these domains are interconnected. And together, they provide a complete understanding of how individuals engage with antimicrobial resistance within the food system. A cross-sectional study was conducted among adults in Barbados using an online questionnaire. This approach allowed us to capture a snapshot of public understanding and behavior at a specific point in time. Each KAPP domain was scored individually with a total composite score of 39. This scoring system allowed us to move beyond individual responses and instead assess overall patterns across domains. Scores were then categorized into low, moderate, and high levels, and this helped to simplify interpretation and identify where the population was concentrated. Ethical approval was achieved. Descriptive statistics was used to summarize demographic characteristics and KAPP scores. We used frequencies and proportions for categorical variables and measures such as means and standard deviations for continuous variables. For inferential analysis, chi-square tests and t-tests were used to explore associations, and a stepwise logistic regression approach was then applied to identify predictors of higher KAPP scores while adjusting for potential confounders such as age, gender, and education. And this allowed us to better understand which factors were most strongly associated with knowledge and behavior. A total of 354 responses were received, with 200 complete responses included in the final analysis. Participants ranged from 19 to 78 years with a mean age of 46. The target age, the largest age group, sorry, was 45 to 49 years old. The sample was predominantly female, and most participants had tertiary level education. And this profile suggests a relatively educated sample, which is important to consider when we look at the interpretation of the findings. Awareness was high, but understanding was uneven. And while all participants had heard about antibiotics, 8 in 10 of them had heard about antimicrobial resistance. But when we started to look deeper, 6 out of 10 correctly identified bacteria as the target of antibiotics, and only 3 out of 10 persons recognized antibiotic use across humans, animals, and crops. And then half were aware that antimicrobial residues can pass through food. So these findings suggest that knowledge is present, but it is fragmented and it lacks depth. This is important because incomplete understanding can lead to misinformed decisions and behaviors. We observed low trust, high uncertainty, and low confidence in food systems. Only 1% of participants fully trusted that food is safe from antimicrobial residues. Nearly half expressed distrust, and many were unsure about key issues, such as whether cooking removes residues or whether AMR contributes to foodborne illness. Confidence in regulatory systems was also low. And this combination is important because when people lack trust and clarity, it becomes difficult for them to make informed decisions. It may also reduce their willingness to rely on public health guidance. This was one of the most important findings, a clear gap between attitudes and behavior. On the one hand, we saw that attitudes were strong. There was high concern about antimicrobial residues, strong support for reducing antibiotic use, and a willingness to support stronger regulation. However, this was not reflected when we look at the practices. Most participants did not routinely check food labels, and few actively sought antibiotic-free products. So while people care, this concern is not consistently translating into action. This reflects what is often described as the knowledge behavior gap, and it highlights the need for interventions that go beyond awareness and actually support behavior change. Overall, scores were generally low to moderate across all domains. Knowledge was lower among younger individuals. Higher educational attainment was associated with higher scores, and most notably, education was the strongest predictor, with individuals approximately 7 times more likely to have higher KAPP scores. And this underscores the importance of health literacy in shaping and understanding behavior. Therefore, this study highlights a clear disconnect between awareness, knowledge, and behavior. While awareness is high, understanding remains limited and inconsistent. And at the same time, individuals express concern and support for action, but their behavior does not consistently reflect this. This gap creates conditions that may contribute to the development and spread of antimicrobial resistance, which means that awareness is not enough. There is a need for targeted interventions that strengthen knowledge, improve risk communication, and support practical and informed decision-making. Ultimately, addressing antimicrobial resistance requires not only strong policies and systems, but also an informed, engaged, and empowered public. Thank you. The one over there. this just looked at what was in the food supply. So that was not a question that we would have asked our participants, because unless you are the farmer, the person responsible for producing your food, you wouldn't know if an entire cycle or course of antibiotics would have been used in food production. But that was not something that we had explored, no.
Question here. Thank you. Thank you for your presentation. Quite interesting. I'd never considered thinking about the food angle to antimicrobial resistance. So I have to congratulate you for that insight. The question I have though is around the types of food that people eat. So if I'm a vegetarian, is that a concern for me? And would that be something that you would have explored amongst your participants?
That area was explored only as it relates to the different areas in food that antibiotics can be used. So if you're going to use your vegetarian approach, we would have asked persons if they are aware that antibiotics, antimicrobials are used in crop production. And results, some people, a lot of people they weren't aware. They didn't know. So for someone as a vegetarian, then it's possible that you may not be aware, because I think that's the one where you only had like 3 out of 10 people knew the broad spectrum, the range in which antimicrobials are used.
I know we have a question over here. Please go ahead.
No, it's strictly on the food side. Sorry, no.
Yeah, could we, human behavior is often the forgotten factor in disease control and antibiotic usage. Could you break down if there was any age differences in your responses and awareness?
Age differences. Well, we did, the survey was open to individuals 18 and over, and what you would say more middle-aged group were the persons that responded the most and had the highest knowledge of what was going on as it relates to AMR in food supply.
And then one question down here.
What kind of campaigns were they exposed to your study group?
Pardon me?
What kind of campaigns, awareness campaigns? Because on one hand, you say there's 100% awareness, but then there's a misconception.
Yeah, so when we spoke about 100% awareness, that was that persons knew that antibiotics existed.
Right.
But in Barbados, there's never been, this is the first time this is done, and there's not been any campaigns educating or informing the public about the presence, of AMR in food. This is the first time this was done.
Okay, last question, please.
Yes, excellent presentation and important topic. Just one minor query I have. You mentioned that there were 354 responses, but you only analyzed 200. What happened to those? Yes, 154 just disappeared. Yeah.
Because those 354 were persons that started, but they did not complete the question in its entirety. And the 200 participants are persons that completed the questionnaire, and we only use completed questionnaires so we can have full analysis.
Yes, that's my question really. Why so many, 43% of the sample didn't complete the questionnaire? That's pretty unusual. And are there implications for bias in those who actually did?
Could very well be, yes. Could very well be a form of response bias or selection bias, because you might have persons who were interested in the topic, that those might have been the ones to complete the questionnaire in its entirety. And also quite possibly, because we saw a lot of respondents had higher levels of education, so that also could have been those persons, completed in its entirety.
Just a comment. I'm sure you're going to write this up in the future. So it's a comment, it's not a question. But following on from Professor Simeon's point, that what you can do in terms of a sensitivity analysis is to look at basic demographics, for example, between the two groups to see if there's any difference. You've also done some inferential statistics using logistic regressions, etc. And you could also take another step and do some imputation type analysis to fill in the gaps of the ones that. So it allows you to use the naive data set with some imputation and then the complete data set which you have. And then you can do comparisons. You can then say, well, there's no real difference between the two groups. So within the population that you test, this is what it's really showing. And then you remove the questions about what about the other population in the future. Right?
All right, thank you. And thank you all for the wonderful discussion. We'll now move on to our next speaker.
And the next speaker is Dr. Achangwa Chabeha, who is a Master of Science Infectious Disease student at the University of Kent. And he's staying in Barbados, and he's staying with antimicrobial resistance.
Thank you, Chairperson, for giving me the floor. I'm really happy to be here today, not as a volunteer, but as a presenter, because I remember last year, I actually volunteered with the CARPHA conference in Barbados. And I'm really impressed to share my findings today on my research. My research topic that we are going to talk today, this morning, is the investigations of the frequency of antimicrobial resistant patterns of gram-negative infections in Barbados. Sorry. Oh. Okay. Yeah, as we all know from my colleague, antimicrobial resistance is a major global public health threat. And in 2019, antimicrobial resistance alone was responsible for about 1.27 million deaths directly and nearly 5 million associated deaths. And this number is projected to go right up to about 10 million deaths annually by 2050 if effective measures are not taken. That's why we are here today. And in Barbados, despite the small population, antimicrobial resistance alone was responsible for 79 deaths in 2019. And antibacteria such as E. coli, Klebsiella pneumoniae are some of the main contributors of this burden. Despite these growth challenges globally, there is limited recent data on gram-negative infections in Barbados. And more to that, there is increasing antimicrobial resistance across the Caribbean with emerging resistance in Enterobacteria to key antibiotics. For this reason, there is a need for updated local surveillance data. And this study addresses this gap in order to contribute to local antimicrobial stewardship and local antimicrobial surveillance in Barbados. We had as our objectives, firstly, to determine the frequency of gram-negative infections among hospitalized and non-hospitalized patients in Barbados from 2022 to 2024, and secondly, to assess antimicrobial resistant pattern in gram-negative isolate, and lastly, to identify factors associated with antimicrobial resistance in Barbados. To attain our objectives, we carried out a retrospective cross-sectional study at the Queen Elizabeth Hospital. We review records from January 2022 to December 2024, and our population consisted of patients with cultured confirmed gram-negative infections. We did a consecutive sampling method, which enabled us to actually review 1,550 records, which is actually a huge number. And our specimen mostly came from blood, urine, and wound swabs. Antimicrobial susceptibility testing was interpreted according to the UCAST criteria, and data collection was done into standardized abstraction form, and then exported into STATA version 16.1 for statistical analysis. Chi-square test was used to compare the differences between the two groups, and then the Fisher-Exact test was used where appropriate. Logistic regression was actually applied, was used to equally look for independent factors associated with antimicrobial resistance among gram-negative isolates. A significant value of less than 0.05 was considered to be statistically significant, and ethical approval for this study was obtained from the University of West Indies Institutional Review Board. Our results from the result, from patients' characteristics, majority of our patients were actually hospitalized patients, accounting for almost about 73.9% of our sample. And as what concerns hospitalization among patients with gram-negative infections, we realized that the hospitalization varied according to age group. For example, the highest burden of gram-negative infections was actually noted in older patients between 40 to 50 years old and 60 years and above. And this difference was statistically significant. As what concerns the distribution of gram-negative infections by organism, E. coli was the most common in both groups, followed by Klebsiella pneumoniae. And however, A. Bomani was also observed in hospitalized patients, and this distribution differed significantly. As what concerns antimicrobial susceptibility patterns, among all the antibiotics that were tested, we noted high sensitivity to amikacin, carbapenems, and tigecycline. But however, there was high resistance to ampicillin, tetracycline, and trimethoprim. As what concerns multiple drug resistance distribution among gram-negative isolate, the overall prevalence of multiple drug resistance was 41.4%, and we noted that this burden was higher in non-hospitalized patients, which is actually a cause for concern. As what concerns the factors associated with antimicrobial resistance, we noted that the only significant factor was organism type, which in this case, Klebsiella pneumoniae had higher odds of developing antimicrobial resistance, and patients with Pseudomonas aeruginosa actually had lower odds of developing antimicrobial resistance. But this should be interpreted with caution because, as we all know, that Pseudomonas aeruginosa is one of the main contributors of antimicrobial resistance. But in this setting, it was a bit different because most of the drugs that were tested were actually susceptible to, they were mostly anti-Pseudomonas agents, which are readily sensitive to these infections. Other variables such as sex, age, specimen type were not statistically significant. As conclusion, multiple drug resistance remains a significant concern, affecting over 40% of gram-negative infection. Notably, higher rates were noted in the community, which highlight a worrying shift beyond healthcare setting. As my colleague earlier mentioned, most of our focus on antimicrobial resistance has been at the hospital because of the selection pressure. But from our findings, E. coli remains the most common pathogen, while Klebsiella pneumoniae is strongly linked to resistance with declining antibiotic effectiveness. Treatment is becoming increasing challenges. Overall, as take-home message, antimicrobial resistance is no longer confined to hospital, but it is rapidly rising in the community, posing a severe threat to effective infection management. This highlights the urgent need to strengthen surveillance, enforce antimicrobial stewardship, and promote responsible antibiotics use at all levels, especially at the level of the community where patients actually get treatment without prescription. Despite these findings, our study had some major limitations. It was actually a retrospective cross-sectional design, which we had a lot of. We had a lot of things to actually compare. We wanted to look at a trend across the years, that's from 2022 to 2024, but unfortunately, we could not look at this trend because of missing data or incomplete data. And we actually noted that there could be a possible underrepresentation of community infections because we didn't actually consider one of the major public health laboratory in Barbados, which is the Best Dos Santos Public Health Laboratory, where most of the community patients go there for antimicrobial, for culture testing. For this reason, we recommend that prospective multicenter studies should be done to evaluate clinical outcomes and drivers of community-associated and drivers of community-associated antimicrobial resistance in Barbados. I will end by thanking my supervisor, the Department of Public Health, Faculty of Medical Sciences, University of West Indies, the Queen Elizabeth Hospital, and the laboratory and data management staff of the Queen Elizabeth Hospital. Then I end up by thanking Queen Elizabeth Commonwealth Scholarship for giving me this opportunity to study at the University of West Indies Carefield campus. Thank you for your kind attention.
Thank you, Dr. Chabeha. Any questions from the audience?
All right, good morning. Thank you for that presentation, Dr. Rama from Georgetown Public Hospital. I have two questions. Were you able to determine how many of your isolates were extended spectrum beta-lactamase inhibitors or ESBL pattern? And your most common organism was E. coli. Were you able to correlate your specimen type to organism? Because it's quite unusual for E. coli to be, unless it's urine samples, to be in the blood, present in the blood or from a blood culture.
Thank you so much for your question. But in this research, we considered 3 specimens were actually considered blood, urine, and E. coli. But our objective was actually to determine the most frequent gram-negative infection and then see and then characterize the antimicrobial resistance pattern. But however, we have that data, but it was not part of our objectives. So we had that particular, I think like most of we tried to analyze to see if we distributed the organism types into the specimen type, but that particular results are not here because of our objectives.
Thank you.
Yeah.
Hi, congrats that you were able to get the data out from Queen Elizabeth. I know it's quite fast. On the second point, you said non-hospitalized versus hospitalized. The non-hospitalized, when they go to a tertiary hospital, they could be very well be follow-ups where they were hospitalized, let's say 7 days ago or 5 days ago, and they could probably be showing infections that are hospital acquired, most likely, but you've been classifying them as non-hospitalized. So did you look into that? And then the percentage that you have for community, of course, because you don't have the larger data, it would always end up being higher because you have a very small proportion of the community infections that you're actually looking in.
That's a very good question, and thank you so much for that question. Normally, in this case, we consider non-hospitalized patients as patients whose sample were taken as an outpatient, and then patients whose samples were sent from other polyclinics around Barbados to the main tertiary hospital, which is the Queen Elizabeth Hospital, for culture testing. Those are the patients that we actually consider as non-hospitalized patients. Hospitalized patients were patients that were actually admitted at the Queen Elizabeth Hospital at the time of specimen collection. So we didn't actually try to find out, we did actually have a variable about prior antibiotics exposure, but we could not actually get it from the medical records because of the retrospective nature of the study. But it's a good point. Thank you.
Okay, if there are no further questions, thank you very much, Dr. Chabeha.
All right, our next speaker is Ms. Chanel Frazier. There you go. Chanel is a student at the University of Guyana, and she's going to be speaking to us about microbial analysis of instant rice produced in Guyana.
Good morning, everyone. So this study was conducted in collaboration with the Guyana Rice Development. Okay, thank you. Yes. So the microbial analysis of instant rice produced in Guyana. This was conducted in collaboration with the Guyana Rice Development Board. because instant rice is under consideration for production. And with any food product, we know that shelf life is critical. So in this study, we examined aerobic plate count and assessed yeast and mold growth in instant rice over a 6 months period as part of the shelf life study. Rice is one of the most widely consumed staple food globally, feeding billions of people every day. It is one of the largest agriculture industry in Guyana, and there is a growing demand for instant food because of convenience and hectic lifestyle, etc. However, safety during storage remains a critical concern as it can cause food safety and public health concern if contaminated. This raises an important question. How safe is instant rice during storage, particularly in tropical environments? Our research aimed not only to detect the level of microbial contamination of stored instant rice produced from local varieties in Guyana, but to identify if there is a difference in microbial quality of instant parboiled rice compared to that of instant white rice stored for 6 months. So to understand these risks, it is important to recognize that contamination in rice can occur at multiple stages. We have before harvesting, which is during cultivation. During harvesting, this can happen with the use of contaminated harvesting equipment. After harvesting due to poor handling and hygiene, improper storage conditions of finished products can contribute to bacterial and fungal growth. So conducting a microbial analysis of the product allows us to check for contamination and to see how long it will survive on the shelf before it cannot be consumed. In the production of instant rice, some microorganisms can survive the pre-cooking stage. They are heat-resistant bacteria, for example, Bacillus cereus, can transform into bacterial spore when exposed to unfavorable conditions. Here we have some microorganisms that can contaminate rice. We have the Bacillus cereus, Staphylococcus aureus, Campylobacter, and Aspergillus flavus. We analyzed a mixed variety of locally produced instant white and parboiled rice that was obtained from the Guyana Rice Development Board. The samples were analyzed monthly over a 6 months duration. So we used 25 grams of rice, which was grounded in peptone water, to create a homogeneous mixture. Each treatment was done in duplicates. We used the cereal dilution, which was 10 to the negative 3 to 10 to the negative 5, sorry. We did a spread plate technique for the enumeration where we take 1 ml of the dilution and pipette it onto the Petri plate and then spread it evenly. The plate conch agar, which was used for aerobic bacteria, this was incubated at 37 degrees Celsius for 24 to 48 hours. We used the potato dextrose, which, for the yeast and the mold, and this was incubated for 3 to 5 days at 37 degrees Celsius also. We used SPSS software. We did the descriptive statistics to summarize data. ANOVA was used to determine the significant difference between the sample, where p-value less than 0.05 considered statistically significant. For our results, so our findings show that microbial stability decreased with storage time. In parboiled rice, looking at the aerobic bacteria, this the one with the red line, we had a slight fluctuation over the 6 months period with a high level of contamination at the 6 months. Even though we had a fluctuation, the aerobic bacteria count showed no significant variation over time. However, looking at the graph on the right, which with the green line, the yeast and mold increased significantly, particularly at month 5 and 6. This showed that there was a significant difference in the treatment. This indicates that parboiled rice is more susceptible to fungal contamination during prolonged storage. In contrast with the white rice, we had a significant increase in aerobic bacterial growth over time, particularly a sharp increase at the 6 months, where we had 7.67 log CFUs per gram. There was a significant difference between the treatment. And for the graph on the right, the yeast and mold growth, it showed no significant variation across storage. Though we had a high value recorded at the 6 months. This suggests that white rice is more vulnerable to bacterial contamination during storage. Here we did a comparative analysis using a supermarket instant rice to compare with our samples. And we found that the commercial product showed higher microbial load, as can be seen with TNC is too numerous to count. And for the yeast and mold, it is higher than the instant parboiled and white rice. In conclusion, this study showed that bacterial spore and fungal contamination remain key risks to the microbial stability in rice. The ability to withstand microbial growth decreased over time based on microbial threats observed over the 6-month storage period. The estimated shelf life of instant parboiled rice is approximately 4 months. This was due to the increase in fungal growth at the 5 months. While instant white rice demonstrates a slightly lower shelf life for approximately 5 months, this was because we had a high bacterial load at the 6 months. These findings highlight the role of microbial dynamics in determining product stability. So proper storage conditions are essential to ensure the safety and shelf life of instant rice. For further studies, it would be important to look at the specific identification of microorganisms that can contaminate instant rice. controlled storage conditions, for instance, checking temperature and humidity, improved processing and packaging, whereby we can use vacuum seal packaging. This will further strengthen food safety standards and risk assessment. In acknowledgement, I would like to thank my research. Okay, Jashila Banke and Arita Singh of the University of Guyana and Ms. Gangadai Dindial, Research Station, Guyana Rice Development Board. Thank you.
Do we have any questions from the audience?
One over here.
Go ahead.
Yeah, that was very interesting, particularly given the sort of widespread use of rice across our communities. So my question to you is, and I think you've addressed it in the last slide where you talked about future work of typing the microbial populations, but have you looked at whether cooking processes remove the risk that is shown by the yeast or by the different microbes?
Thank you for your question. No, we did not look at that.
There?
We did not look at it.
Okay. Well, that would be very interesting, given that, you know, sort of if they sort of survive those conditions, and clearly it's a major issue that needs to be addressed, and it's good to see you addressing it in your plans, your future plans.
Yes.
Other questions? Okay, well, thank you.
Thank you.
And we'll now have our last speaker of this section.
And that last speaker is Dr. Navindra Prasad, who is a medical intern at the Georgetown Public Hospital. And his presentation is provocatively titled, Walking with the Enemy. Dr. Prasad.
Not here. Okay, so good morning, everyone. It's my esteemed privilege to present my presentation on behalf of my esteemed colleagues today. So this was a study done in collaboration with the Georgetown Public Hospital Corporation and the University of Guyana. And it was conducted during the period September 2025 in the hospital's neonatal care unit. So why did we choose to do this study? So the WHO classifies our neonates as one of the most vulnerable populations in the world, right? Although neonatal mortality rates have declined by 44% since the 2000s, in 2023, over 2.3 million neonates have passed away. So that's for every minute, at least 4 neonatal deaths have been recorded. It's been a constant battle for survival, and one of the biggest contributors to neonatal mortality has been hospital-acquired infections, especially those secondary to bacterial infections. Now, if I'm to ask you what you think the most contaminated item is in a hospital setting, you might think of the floor, the toilets, or the bedroom. But what if I tell you that it might be the very item that you have in your pockets or even in your palms right now? So, cellular phones have become ubiquitous in our hospital settings, moving from bed to bed during ward rounds, moving with us from ward to ward, and even from our homes into the hospital settings, thus making them the perfect fomite to spread infections to our neonates. Hence, my colleagues and I would have postulated that this friend that we might be carrying around, instead, rather, we might be walking with the enemy. So in our study, we aim to quantify bacterial load. We identified bacteria clinically implicated in late onset neonatal sepsis, evaluated mobile phone hygiene practices, and examined the overlap between positive blood cultures among neonates in our neonatal care unit and bacterial species isolated during our study. So we used a mixed method conversion cross-sectional study where we included a knowledge, attitudes, and practices questionnaire with a microbiological analysis of 76 samples split evenly between healthcare workers and mothers admitted to the ward at the time of the study. So mothers were chosen by random sampling with an inclusion criteria of them owning a cellular phone and being admitted to the hospital's unit for more than 24 hours. Our healthcare workers were chosen by convenience sampling, and it was included solely to healthcare workers that were rotating within the neonatal unit at the time. So each participant would have been given a piloted questionnaire which addressed mobile phone usage and their hygiene practices. And concurrently, their phone screens would have been swabbed with moistened saline swabs. And these samples would have been taken to the University of Guyana microbiological lab, where they would have underwent serial dilutions, 10-fold serial dilutions, and placed on nutrient agar, where they were incubated and observed for growth. Here, once there was growth occurring, they were subcultured onto selective and differential media, where the gross morphology and color were recorded. Those growing positive on the MSA were then underwent biochemical testing. That is the coagulase test to determine when they're coagulase positive or negative. And all samples that produce growth underwent further gram stain and microscopy. Further, neonatal cultures, positive blood cultures from the GPHC lab would have been collected for the period September 2025 and compared to that of the bacterial species that we would have isolated. So all our data was entered into SPSS version 27, where t-testing or ANOVA studies were done to determine bacterial load, and our categorical data was analyzed using chi-square with a significance level set at a p-value less than 0.05. So what did we find? So among our healthcare workers, there was a predominance of females, and in our entire study, most of our participants were between the ages of 26 to 55 years old. So this reflects our demographic of a young, predominantly female population. When analyzing our bacterial load, we group them into low, moderate, and high burden bacterial loads based on a study done by Mulvey et al. So the majority of participants, namely 96.1% of them, exhibited a low bacterial burden. This indicates an overall acceptable standard of hygiene and contamination control. However, it was noted that healthcare workers had more than twice the bacterial load than that of mothers. However, this can be explained by healthcare workers being in the hospital for longer hours and more frequently. Nonetheless, this had a p-value of 0.12 and was not deemed to be statistically significant. However, although we did not have any statistical significance, we're in a clinical setting, and we did identify clinically significant bacteria implicated globally in neonatal sepsis. So 88% of our samples grew gram-positive cocci, the majority of which were coagulase-positive staphylococcus. So 88% of our samples were Staphylococcus aureus. Roughly 11.4% of these samples were coagulase-negative Staphylococcus, so they can be Hemolyticus, Epidermidis, or Saprophyticus. When compared to GPHC's cultures at that time, coagulase-negative staph and Klebsiella were some of the major causative agents of late-onset neonatal sepsis during the study period. Further, about 20% of our population grew coliforms. So Klebsiella pneumoniae and Enterobacter species were also isolated during this study, similar to Barbadian and Nigerian studies who also shared these similar results and indicated their relevance in a clinical setting, especially in neonatology. Of note, we did not recover any E. coli isolates. So the study also found that the phones of healthcare workers had a higher bacterial burden in that most of them grew more than one type of bacterial species when compared to non-healthcare workers or mothers, where most mothers would have grown only one species. So these were just some images of our plates. The top left would be significant for Staphylococcus aureus on our MSA plates. In the middle, that's our EMB, suggestive of Klebsiella and Enterobacter species, and then positive coagulase test. And at the bottom is just some pictures from our microscopy and gram staining. Good. So from our questionnaires, what we would have noted is that although we didn't have statistically significant correlation happening between hand hygiene routines and bacterial load, we did notice some behavioral patterns. So almost 1/4 of our participants, mostly mothers, reported never cleaning their mobile phone devices. And among those who did clean their phones, alcohol swabs were the most prevalent. Almost 40% of our participants admitted to using their phones in restroom facilities, and this was more common among healthcare workers, which may explain why more coliforms grew on their phones. It is very important to highlight that all participants reported that they washed their hands after using the washroom, and there's a high awareness given that 96.1% of participants believe that phones can harbor and transmit microorganisms, but there is a knowledge behavior mismatch in that this was not reflected in their hygiene practices in cleaning their phones or washing their cleaning their phones. So our study was limited by a potential recall and social desirability bias. No one wants to say they don't wash their hands after using the washroom. And due to resource constraints, we were unable to determine whether there are any antimicrobial resistance. And additionally, if viruses and fungi would have contributed to late onset sepsis. Recommendations for the future. We would aim to pursue interventional studies where we do multi-center cohort studies to improve the statistical power, as well as longitudinal studies to track the fluctuation in species isolated during outbreaks or at different centers. Additionally, we would like to expand the analytical framework to include viral and fungal pathogens, coupled with the adoption of molecular identification and antimicrobial susceptibility. So this integrated approach would allow for a more comprehensive surveillance profile and yield critical data on resistant patterns to inform empiric treatment guidelines. So in conclusion, while overall bacterial burden was low, there was a high rate of bacterial contamination, and clinically significant bacteria were isolated as it relates to late onset neonatal sepsis. So with that, I'll leave you to ponder whether we really are walking with the enemy. And I'd like to acknowledge our participants, the University of Guyana, and the Georgetown Public Hospital Corporation, as well as CARPHA for giving me this opportunity. Thank you.
Thank you, Dr. Persaud. Any questions for him?
Doctor, could you clarify for me late onset neonatal sepsis? When do you classify a patient as being in that period?
Okay, thank you for your question. So late onset sepsis, there's early onset and late onset. Late onset sepsis begins after day 3 of life, so about days until day 28 of life. So these patients would have been there for at least 3 days. And the most common cause of their sepsis would be because of hospital-acquired infections, which is why we focused on mobile phones leading to that.
I'm asking because normal neonates are discharged within 24 hours, right? So is the conclusion that the phones and the healthcare workers uh, causing or contributing or could contribute to making it worse if you have a patient in late onset sepsis? No?
Okay, so there was no statistical significance in correlating that they're directly causative, but what came out of it is that we walk around with these bacteria that are implicated in late onset sepsis on our mobile devices. And what we would have observed from our clinical rotations, a lot of mothers actually breastfeed with the phone on their bedside. As healthcare professionals, we may use our phone on rounds and so on. So what we're actually trying to say is that there is a potential that we are contributing to late onset sepsis.
Are there any other questions or comments?
Thank you so much for your excellent presentation. I have one question. During your presentation, you did mention the fact that I think hand washing is actually really, really important. So I was just wondering if these infections are coming from the hands to the phone, or is it really from the cell phones? And secondly, is there a possibility that, because I think your future studies, so I would like to probably like see another study, just maybe like take samples of hands so that we should be able to know if probably these infections are actually, because I know about neonatal care, you need to, the neonatal unit, you have to wash your hand before touching the baby and some stuff like that. And during your, I think during like you were asking some few questions, people could not actually tell you if they wash their hands after maybe visiting the restroom or not. So I think it's better, I don't know if these infections are actually really coming from the cell phone or is it from our hands?
Okay, that's a great question. So based on previous studies, this is actually a landmark study being done. Previous studies would have looked at, they actually swabbed the dominant hand of persons rather than swabbing cell phones. So yes, you may be correct in that that is the source of our infection, or sorry, not infection, but the bacteria. So yes, it might be coming from the person's hand, but the proof is that it's actually staying on the phones. And these phones go to our patients' bedsides, and then if it can spread from our hand to our phone, it could spread from our phone to our babies. That was your first question.
Yeah,
Yes.
thank you.
No problem. Did I clarify everything, or?
Yes, please.
Okay, thank you. Maybe we can work together on the antimicrobial resistance.
I will be happy to actually collaborate with you.
Okay, you can have a discussion at the coffee break. Thank you. Any other questions?
Okay, if there are no more questions, let's thank Dr. Persaud for his very interesting presentation.
Thank you.
So we now have a coffee break for about 20 minutes, and sessions will resume at 10:45. It sounds like there's some important scientific collaborations that need to happen at the coffee break, so please enjoy.
our CARPHA conference. I am your co-chair, Dr. Lyris Benjamin. I am a professor and assistant chair at Ross University School of Medicine in Barbados. And co-chairing with me is
Hi, everyone. My name is Dr. Reza Niles Robin, and I'm the Director for Vector Control Services within the Ministry of Health. And it's a pleasure to be here, and I look forward to this session. Just a few housekeeping rules for our presenters. Please be reminded your presentation is 10 minutes, and you have 5 minutes to Q&A. The session liaison, could you raise your hand so they can see you and the cards? So they'll have the time there. We're going to try and defy our odds and be on time for lunch today.
Our first presenter is Mr. Dhanraj Ramkelawan. The title of his presentation is Epidemiology of Human Leptospirosis in Grenada, from 2018 to 2025. It's a retrospective population-based study. He is a senior environmental health officer at the Ministry of Health in Grenada. Okay, so our first presenter, unfortunately, is not here. So we'll go to our next presenter. Our next presenter is Dr. Brian Dawes. The title of his presentation is Evidence of Human, Rodent, and Bat Hantavirus Infections in Grenada. He is an infectious disease fellow at Stanford University in the United States of America.
First of all, thank you to the conference organizers and the chairs. It's been a great conference so far. I'm really excited to be here. So this is a pilot project that we conducted in Grenada that was a collaboration between Stanford University and the Windward Island Research and Education Foundation and St. George's University in Grenada. And so this was a pilot project looking for hantaviruses in humans and animal species. So just a very quick review about kind of the status of zoonotic viruses and infections in Grenada. Some of the animals that we worry about, of course, are rodents that can spread a lot of diseases. In Grenada, we have rats of the Rattus species, so Rattus norvegicus and Rattus rattus, and also the common house mouse, Mus musculus. Importantly, there's no kind of like native endemic rodent species still present on the island as far as we're aware of. They've all been replaced by these invasive Eurasian rodent species. Additionally, there's at least 14 species of bat with a lot of bat-human interaction that's been noted in Grenada. Rabies is present. There haven't been any human cases for a while, but it is present in the bats and some of the other mammals. There's some seroprevalence data for hepatitis E, and leptospirosis, while not a viral infection, is a significant cause of fever in Grenada and the Caribbean in general. And unfortunately, our prior speaker was unable to share his results, which I was looking forward to seeing. So what are hantaviruses and why are we worried about these? And why are we looking? So hantaviruses are a diverse family of zoonotic viruses. Largely, they're spread by rodent reservoirs. So the rodents are chronically infected, and when they urinate or defecate, they can spread the infection to humans by breathing in kind of dried dust and particulates. There's also evidence that shrews and bats act as reservoirs, but their clinical significance for those viruses is still unclear. There's two broad groups of these viruses: the Old World Eurasian viruses, which cause hemorrhagic fever with renal syndrome. In particular, we're interested in sole hantavirus, which is carried by Rattus norvegicus, so the brown rat, which could potentially be present in Grenada. And then the New World hantaviruses are characterized by hantavirus cardiopulmonary syndrome in humans. No hantaviruses, like the actual virus itself, has ever been isolated in the Caribbean, despite the fact that we believe that these have a worldwide distribution. There is good seroprevalence data in Barbados, and there's been several febrile illness series using IgM-based diagnostics that show that this is a potentially significant infection in Barbados. Trinidad has a study reporting 11% seropositivity, and there is at least one case of Sinombre virus, which is a New World hantavirus, from a traveler returning to Europe from Cuba. Ooh. Doesn't like that slide. Okay, so what data do we have about hantaviruses in Grenada in particular? There have been no evidence of human hantavirus infections identified so far. A prior study showed that 30% of Rattus norvegicus had antibodies to hantavirus, indicating potential presence in that rodent population. And again, like I said, we have rats that could carry sole virus, and then there are the mice that, while that species of mouse usually doesn't carry hantaviruses, older New World hantaviruses that were present before the native rodents became extinct could be theoretically present and circulating in these other rodent species. The bats could also be harboring novel hantaviruses. So we hypothesize that sole virus circulates in humans and rodents in Grenada, and that bat hantaviruses may also be present. And so we wanted to use One Health approaches to assess whether this was the case. So we did kind of two studies in parallel. One was a human study. So I'll talk more about the basis of this study in the next talk, but in quick summation, we had a febrile illness cohort that we collected from 2023 to 2025. We had 647 participants who were presenting with fever, and those had been tested previously for arboviruses. Notably, dengue was 15% positive, which we'll talk about later. So we took a subset of 400 random samples from that collection and tested for hantavirus antibodies using a commercial ELISA kit. And then we took 400 dengue negative samples and used a pan-hantavirus family RT-PCR to see if we could detect active infections. And then we also conducted animal experiments. So from 2025 to 2026, we trapped rodents throughout southern Grenada and bats. So we collected 65 bats, 42 rats, and 10 mice. We modified our ELISAs to be kind of species specific for this. We had good positive controls for our rodents. Unfortunately, good bat positive hantavirus controls do not exist for bats. So we are working on validating those a little bit more carefully, which I'll talk about in a moment. And then we did kind of, again, the same studies with RT-PCR. For the bats and rats, we had organ samples as well, so we were using spleen, which should have higher levels of virus. So these are our basic results for the human side of the study. So this violin plot shows our ELISA results, and our cutoff here based on the commercial protocol was 11. So we identified 14 out of 400, or 3.5% of those samples as positive for hantavirus antibodies, with a 95% confidence interval of 1.7 to 5.3% seroprevalence in our population. We also had some 18 samples that fell in the equivocal range, which it's hard to determine if those are truly positive or negative. We also, again, did RT-PCR testing. None of these samples that we tested were detected as positive for active infection. Just a little bit of the seroepidemiology, since we had a lot of information from these subjects. Most of the samples that were positive that we had were from St. George or St. Andrew Parish. So St. George is in the southern portion of the island, and where the capital city and kind of the densest populations are. For the kind of epidemiological analysis in the table, this is very underpowered because we only had 14 positive samples. So there's not a lot that we can really definitively say from this, but because we had the data, we did want to at least look at it and see if we could see some trends that started emerging. None of these, again, were significant because this is very underpowered, but there was a trend towards St. George Parish being more significant. and higher seroprevalence, which could potentially make sense as, again, it's kind of one of the most urbanized setting where you might have more rat-human contact. And then the other interesting one was uncovered rainwater storage. So people who reported storing rainwater but not covering it was the closest to significance that we had. The p-value on that was 0.06. And this, again, is kind of biologically plausible. You could imagine that rats could be drinking or urinating or defecating into this water and contaminating it, and potentially leading to human infection this way. But we would have to have a larger sample set to really have more power for this. So for our animal studies, I'm actually going to start on the right side with the mouse. We didn't find any that were convincingly seropositive for that, but that's very limited by a very small sample size of only 10 animals. Again, I don't think that there's New World viruses necessarily circulating, but this is really too small of a sample to have large conclusions from. For the rats, we found a seropositivity of 21%. And that confidence interval fits really nicely with the previous 30% serological study. So this suggests that there's still ongoing transmission and ongoing circulation within the rat populations of some hantaviruses. And then for the bats, I mentioned that we didn't have well-validated positive controls. So this is kind of a preliminary result where we're estimating 26% seropositivity. What we did was we took that highest value with an absorbance reading of nearly 4 and used that as a presumptive positive because a lot of these values for the bat samples were actually quite high. It's more for the lower end that we're uncertain where we would put our cutoff. So we are working with a lab at the University of Colorado who has a lab-raised bat colony that should be, in theory, negative. We ran one of those samples, which is the very, very, very bottom one with very low signal, but we're getting a larger sample set so that we can run a bunch of validated negative controls and get a good standard deviation from that. So this is a little bit preliminary in terms of our estimated seroprevalence, but we do think that there's reasonably good evidence that there's circulation, just the exact amount we're a bit less sure about. And again, we used a pan-hantavirus RT-PCR on all of these samples, and none of these were positive. Another note and limitation about this nested PCR protocol, because this is a pan-family PCR, there is a lot of non-specific amplification. We sequenced areas that look like they might be positive. They were all not positive. We're going to be repeating these with some species-specific primers, particularly for Sol virus, which should be more sensitive. So in conclusion, we have the first evidence of human hantavirus infections in Grenada with a seroprevalence of 3.5%. Human infections may be more concentrated in more urbanized areas. And again, while this is under power, there's maybe some signal hinting towards uncovered rainwater storage as being a risk factor. We also have evidence of ongoing circulation of hantaviruses in the rat population with a seropositivity of 21%. And which is suggestive of ongoing Sol virus circulation. And the estimated seroprevalence we have for bats is 26% with some ongoing work to really finalize that. And importantly, we have no active infections that we were able to detect from these cohorts. So with that, I want to thank all of our partners. This was a great group collaborative effort with Windruff and St. George's University, particularly Sonia Cheatham, who is the vet on our team, who spearheaded a lot of the animal work and was really invaluable. Stanford University, and of course, the Grenada Ministry of Health, and the SGU, IRB, and IACUC boards, and our human study participants. The overall human study was funded by an NIH grant, and then the hantavirus portion was funded by a seed grant from the Stanford University Center for Innovation and Global Health. And with that, I'm happy to take any questions.
Okay, so we now invite questions from the audience.
Brian, thank you for that presentation. It's a great example of a One Health study. I think you showed quite nicely that there is a high level of infection in animal populations in Grenada. Why do you think you didn't get any PCR positives in any of the samples that you looked at?
Yeah, so I think there's a couple of things going on here. One, there are limitations with the pan-family PCR in terms of sensitivity. We talked with CDC about these assays in well, and even in their hands, and they're the gold standard world reference lab for hantaviruses, they don't really like this assay. It's a very insensitive assay. So hopefully when we repeat this testing with species-specific primers, we'll have more sensitivity. For the humans, the seroprevalence is very low. At 3.5%, so it's not surprising we weren't seeing any positives. And then for the rats, the sample size of 42 is still pretty small, so I don't think it's that surprising that we didn't catch any active infections. But hopefully with an improved sensitivity, we might be able to pick up some in the coming months.
Thank you so much for your study. I found it interesting that dengue, you had, I think, 2 positive dengue samples that were also co-infected with the virus. From the clinical point of view, if you have that information, was that person severely sick or was this like an outpatient person?
Yeah, so that was not co-infection. It was someone who had hantavirus IgG antibody and was positive with dengue at the time that they were recruited into the study. So we looked at that just to see if the people who were getting dengue had, that was somehow associated with prior positivity, but it wasn't an active co-infection. Unless we go back and test it and see. But so far, no active infections that we found.
I do not see any additional questions for this presentation. However, Dr. Dawes does have another presentation for us, and this one is entitled Diagnosis and Epidemiology of Arbovirus Infections in Grenada. And this study is from 2023 to 2025.
Thank you again, and happy to share these results as well. And so this is similarly a collaboration between our group at Stanford and Windriff and SGU. And additionally, we have a collaborator on this project from UC Santa Cruz as well. And so this was a project that was undertaken from 2023 to 2025, looking at diagnostic development for arboviral infections. The diagnostic development side, we won't really talk too much about. That was the UC Santa Cruz really leading that effort. But we will talk about our PCR-based diagnostics and the epidemiology that we observe. So I think, of course, this crowd is very familiar with the fact that diagnosing acute febrile illness is oftentimes very challenging. Accurate diagnostics may not be available, and clinical diagnosis is often very unreliable due to nonspecific presentation for a very wide variety of potential infectious and non-infectious etiologies. And so in regions like Grenada, where we have a lot of dengue present, things can fall under the dengue umbrella. People receive a clinical diagnosis of dengue without laboratory confirmation, and it could be masking other things that are circulating as well. So that was one of the lead reasons that we want to define this a little bit more clearly. So in Grenada, of course, Aedes aegypti is present. All 4 dengue serotypes have been documented with previous seroprevalence studies showing 93% seropositivity. And like the rest of the Caribbean was affected by the large chikungunya and Zika outbreaks in the 2010s. There's some serological evidence of other viruses such as Busacara and Venezuelan equine encephalitis, but no documented human infections in humans. So our objective for this study was to perform a febrile illness surveillance study and test for a variety of arboviruses using multiplex PCR and then associate factors associated with infection. And again, this was a large collaborative effort. So as I mentioned in the prior talk, this was a febrile illness cohort that we collected. So participants were greater than 1 year of age, had fever at the time of enrollment, and of course, provided consent for participation. Patients were recruited from public and private labs, clinics, district health centers, and within a few months of the project getting started, we also had a lot of community outreach and home visits. So we had workers going out into the community, seeing if anybody at the time had active fever that we could collect samples from, and then also giving information so that if they or anybody they knew developed fever, we could come out and get samples directly, which was really nice because I think, as was mentioned this morning, a lot of people who develop these illnesses don't always present to healthcare, especially if they have more mild disease. So this allowed us to really increase the amount of people that we were enrolling with more mild clinical disease. So we ended up enrolling 647 participants from 2023 to 2025. At the time of enrollment, they also completed surveys on potential risk factors. Once we had serum, we performed multiplex RT-PCR for a variety of arboviruses, and we also provided rapid IgM testing if available. And then we performed statistical analysis with bivariate analysis using t-tests, chi-square tests, and Fisher's exact test, and then multivariable logistic regression for our final risk factor analysis. So we used a PCR assay that we call our ZCD assay. This is a multiplexed pro-based PCR that tests for Zika, chikungunya, and a pan-dengue primer probe set. So this can tell us if it is dengue positive or negative, but doesn't tell us the exact serotype with this assay. And then we had an internal human RNase-P control for quality, and we used synthesized single-stranded DNA positive controls for these sequences. So these are our overall testing results of our study population of 647. We detected 98 PCR positive dengue cases for about 15% of that population. We detected one chikungunya case. We reran this test over and over to make sure that this was a true positive, and it was consistently positive. So we did have at least one chikungunya virus infection that we found, and no Zika virus cases. I think it is important to note that nearly 84% of these cases remained undiagnosed with this, and that, again, we only had 15% PCR positivity for dengue in this cohort. So a little bit of descriptive epidemiology. On the left, we have a map of Grenada and our distribution of cases. So about 40% of our samples came from St. George's Parish, and that is where we saw the majority of our positives, and they also had a higher positivity rate of about 23%. The other parishes had positivity rates from 4 to 17%, but we did see higher rates in St. George Parish. And looking at our age distribution of cases, in blue is our overall recruitment, and then red are the dengue positives. There's no statistical difference in terms of positivity rates. There is a trend for the younger populations to have higher positivity rates, particularly in the 2 to 5 and the 13 to 19 age groups. But those were also smaller in terms of the number of people we reported. So that's kind of underpowered for that. And the majority of who we were recruiting were young adults in kind of the 20 to 44 year age range. And this is just an epidemic curve of what we were seeing over the course of our study, starting again in May of 2023, running through October of 2025. You can see where the red pops up tends to be in Grenada's rainy season, so June through October is when we were seeing all of our dengue positive cases. So we are seeing seasonal endemic transmission for the most part. And then in 2024, like most of the rest of the region, we experienced the surge in dengue cases with quite a large epidemic that occurred. And that was actually where we were recruiting most of our patients. And the PCR positivity rate jumped from 10% in these more endemic periods to 20% during this epidemic period. And that green star represents when we detected our one chikungunya case. So I won't go into all of our kind of like bivariate analysis, and I'll just jump to our adjusted model using multivariable regression for the risk factors that we identified in this study. So the significant risk factors that continually popped up for us were parish, and particularly St. George Parish had an odds ratio for us of 2.08%, suggesting that there is more dengue that we were detecting in St. George's Parish compared to other regions. Living in an apartment rather than living in a house or a freestanding house was our strongest risk factor that we consistently identified, which may have some implications on infestation have window screens. And it's also important to remember the ecology for Aedes aegypti. These are day biters, so people might not be getting infected in their homes. It might be at work or outside. This was just very interesting that this consistently popped up, although clearly this is not causal because these should be protective. And then the epidemic period, of course, had more cases. We did some interaction analysis to see if there were any changes in risk factors during the more endemic periods versus the epidemic period. And what we saw were higher rates in St. George, particularly in younger and student populations during the epidemic. So it did seem like it was affecting a younger population during the 2024 epidemic. So we have a couple of ongoing studies with this. We're working on serotyping all of our dengue positives so that we can have a little bit more information in terms of which serotypes were circulating and if there was a serotype switch that led to this epidemic. And we're doing a few more adjusted analyses at the parish level. So in conclusion, we were detecting seasonal endemic dengue transmission with a PCR positivity of approximately 10%. We had a large 2024 epidemic with PCR positivity of 20%. And during the epidemic, we had a younger population that was more concentrated in St. George Parish. Apartments were significant risk factors, and we had this association with window screens that is interesting, but we don't think is causal. And I think this also really highlights the need for continued improvement in diagnostics, given the really high level of negative testing that we were seeing. And again, I want to acknowledge our very large and excellent team at Windriff and SGU, at Stanford, at University of California, Santa Cruz, and then the Grenada Ministry of Health, the SGU IRB board, and of course our study participants. And this was an NIH-funded study. I'm so happy to take any questions.
Brian, can I ask you, so 85% of fever was not caused by dengue at a time when almost everybody in the country felt that they got dengue when they had fever. What sort of tests would you want to include to try and make sure that, because it's the same problem everywhere in sub-Saharan Africa, I think, because they have such a high incidence of malaria in certain cases, they get treated. Obviously with dengue, no treatment, it isn't an issue, but what other sort of testing could we include to try and capture a greater proportion of the fever cases that are found in the population?
Yeah, I think that's the million-dollar question for these sorts of studies. So I think a few more granular details on that. Dengue diagnostics are tricky. Of course, you're only viremic for a certain period. So some of these people probably had dengue, but were past the viremic period, and so we just were missing it. And if we had consistently done IgM testing, we may have had a higher percentage. We did have, I believe it was 10% IgM positivity when on the subset that we did have the rapid tests for however well those perform. So it does increase things a little bit more, but still does not account for that huge gap. I think there's probably other arboviruses that we aren't appreciating. So we're going to be doing some testing for Oropouche virus and Mayaro coming up. We're also going to try to test some of these for leptospirosis as well to see if what the burden of infection for those is in this population. I think at some point, what I would really love to see done is some really granular studies, particularly with things like metagenomics, to really just define what is circulating at what levels, and then that can lead to diagnostic development and deployment for the things that are the most missed at some point.
Well, you preemptively answered my question, but I'm Lucy Rudin from the NIH NIAID, so it's great to see our funding in action here. And I was also noticing the large amount of negative results, and was going to flag or ask if you've been considering how the Oropouche regional outbreak did intersect quite heavily with the dengue outbreak, and that specifically that surge that you had in September 2024 really flagged for me. So it sounds like you're looking into it.
Yeah, and I think that that was another, it looks like there's some sort of arbovirus there, right? When dengue surged, there was a huge amount of non-dengue that also surged at the same time. So we're going to test all of those samples and see. I also wonder if Oropouche has been present in Grenada undetected. It is in Trinidad where it was first discovered, which is very, very close to Grenada. So it'll be interesting to see even pre-2024 if we detect any. Yeah.
Great.
Do we have any other questions? So I think this was very interesting in the way that you were able to identify certain parishes that were higher prevalent of the arbovirus. I'm just wondering, in terms of the window screens, that one was kind of definitely reverse to what you would have expected. In terms of follow-up studies, from a public health perspective, what would you think in terms of education or, stuff like that?
Yeah, I think that's really hard. Of course, we want to make sure people are using their window screens correctly. And I can anecdotally say that I don't always see that being the case. But from a formal research perspective, I don't have that data. I don't know how big of an impact that would have. Again, I don't know whether this is just kind of a curious association that we're seeing, or if it's something that really warrants a lot of time and resources to go after it. I think the apartment risk factor was something that is a little bit more actionable, because that's the highest signal that we're consistently seeing, and that's, I think, a built environment that has biological plausibility for why there might be more 80s living there. They love human built environments. So I think that would be the risk factor from this that pops out to me as the area that we could intervene on more, whether that's more vector control efforts concentrated in areas with more apartments, or more education about water and trash management around those environments.
If I could just make a comment on the window screens, I think it's a little. It's really the population that you found that was positive. It's where they are during the day, and they're rarely at home during the day. So the presence of window screens really doesn't impact on the epidemiology of dengue in a big way, especially with a young and working population. It's what is the environment like where they're working or where they're at school?
Definitely.
Building on what was mentioned there, you had 3 years, 3 years on your graph. It seems to be August, September, and in the first one, you had some months or late months leading up into that, and then the other 2 years, there's no information. Are you going to go back there to see if you're missing data that points, because it's in the next 2 years, it's just August, September, and then it disappears. Because I'm looking at that because what is going on around those 2 months that you're having those cases? Because for the window screens, it's an odd thing, right? So is it that you have visitors coming to the island, or vacationers, people going out and coming back in? What?
Yeah, so a couple of, I think, comments on that. First, when I overlay this, I think I had that as an extra slide in there, but if we overlay this with the PAHO reported cases, it fits pretty closely as well. So I don't think that we're having some sort of spurious sampling issue in terms of why we're seeing the spikes really in that seasonal pattern that is during the rainy season. So there may be some climatic component in terms of like population shifts. Carnival is in August, which may have some component for that as well. Although we usually do see cases starting to rise earlier August and July as well for some of those months. So I don't know if there's causality for that, but there is a population
Yes, because
coming
then
in for
on
that.
the other presentation, it might be a group that we're not sampling to see what is actually the types that we're having.
Yeah, yeah, it'll be interesting to see if that was a serotype switch that caused that big epidemic.
Okay, let's give him a clap. Thank you so much for your presentation. I'm now going to call on Vanessa Matthew Belmar. She will be presenting on comorbidities and mortality during the SARS-CoV-2 outbreak in Grenada. She is an instructor at the St. George's University in Grenada. Please go ahead.
Good morning. My name is Vanessa Matthew Belmer from St. George's University, Grenada, and today I'll be presenting on behalf of my co-authors. Our presentation is titled Comorbidities and Mortality During the SARS-CoV-2 Outbreak in Grenada. COVID-19 caused by SARS-CoV-2 has been responsible for substantial illness and death worldwide, and its rapid early spread led many countries to adopt strict public health measures and accept major economic disruption. Highly effective vaccines were developed in record time and have played a critical role in reducing severe disease and mortality. In Grenada, SARS-CoV-2 was first detected in March 2020, and in a small population of roughly 117,000 people, more than 200 COVID-19 related deaths have had a significant impact. To control transmission, the government implemented a range of measures, including lockdowns, movement restrictions, mask use, hand hygiene, and physical distancing of about 6 feet to limit droplet and aerosol spread. People with comorbidities like diabetes, hypertension, chronic kidney disease, and cardiovascular disease, or chronic obstructive pulmonary disease are much more likely to develop severe disease and die, especially when they have 2 or more of these conditions. In adults over 71 years, age alone often becomes the strongest predictor of mortality, sometimes more important than any underlying disease. So the objective of this study was to assess gender-specific differences in the distribution of comorbidities among individuals who died from COVID-19 in Grenada and to examine age-adjusted association between sex and comorbidities. A retrospective cross-sectional study was done to analyze the Ministry of Health surveillance data on COVID-19 deaths from January 2021 to June 2022. Confirmed cases were tested positive by real-time PCR. Descriptive analysis characterized the deceased population and compared findings by gender. Mortality rates were calculated by parish using the 2021 census data. Difference in comorbidity prevalence between males and females were assessed using 95% confidence interval, and age-adjusted logistic regression explored the sex comorbidity of relationship. All analysis was performed in the SAS 9.4 with a significant level of 0.05. In this study of 288 COVID-19 dissidents with a mean age of 74 years, males slightly outnumbered females at 52% versus 48%. The leading comorbidities were hypertension, affecting nearly 44% of cases, and diabetes at 34%, followed by respiratory disease, heart disease, kidney disease, and cancer. St. George's Parish saw the heaviest burden with 32% of deaths, followed by St. Andrews at 19%, while Carriacou and Petit Martinique record the lowest proportion of 2%. Turning to the geographic disparities, St. Patrick's exhibited the highest COVID-19 mortality rate at 53.5 per 10,000 population, while St. George had the lowest at 2.3 per 10,000. Though it accounted for the largest share of total deaths due to its bigger population, smaller parishes like St. Patrick's and St. John showed elevated per capita rates but lower absolute death proportion, whereas Carriacou and Petite Martinique contributed just 2% of deaths. At a moderate rate of 12.6. Middle range parishes like St. Andrews had a 21.8 rate, 19% deaths. St. David's had a 28.4 rate with 14% deaths, and St. Mark's had a 25.4 rate with 4% deaths. These displayed patterns aligning with the population size. This slide shows the characteristics of individuals who died from COVID-19, comparing males and females. Overall, females were slightly older at death than males. When we look at comorbidities, hypertension was the most common condition in both groups, but it was noticeable higher in females. Diabetes and respiratory disease were also more prevalent among female dissidents. In contrast, males showed a higher proportion of heart disease, kidney disease, cancer, and other comorbidities. These findings suggest clear gender-based differences in underlying health condition among COVID-19 deaths, which may have influenced disease severity and outcomes. So this table highlights how certain comorbidities differ by sex in terms of their age-adjusted, in the adjusted odds ratio. The findings show that females had significantly higher odds of having diabetes, hypertension, and respiratory disease compared with males. With odds ratio of a 1.64, a 1.73, and 1.71 respectively, each reaching statistical significance. In contrast, conditions such as heart disease, kidney disease, and cancer and other comorbidities did not show meaningful sex-based differences. Overall, these results suggest that while some chronic conditions are more common among females in these samples, others appear to affect both sexes similarly. Based on this provided forest plot, after adjusting for age, there are significant difference in the odds of several health conditions between females and males. Females had significantly higher odds of having diabetes, hypertension, and respiratory disease compared to males. Females have significant lower odds of having kidney disease. There is no statistical significance difference in the odds of having heart disease, cancer, or other comorbidities between the two sexes. Our analysis of COVID-19 mortality in Grenada from January 2021 to June 2022 showed that while overall case fatality rate was a 1.8%, deaths were concentrated in a high-risk group. Nearly 86% of deaths occurred in people with 2 or more pre-existing conditions, mainly hypertension and respiratory disease, reflecting global trends. Most deaths occurred in males aged 60 and above who had multiple comorbidities, especially hypertension, diabetes, and respiratory disease. So this highlights the vulnerability of individuals with chronic illness and highlights the importance of targeted interventions to protect this population in future health crises. In conclusion, from January 2021 to June 2022, COVID-19 mortality in our setting was a 1.8% and was heavily concentrated among patients with multiple comorbidities, particularly hypertension, diabetes, respiratory disease, and pneumonia. More men than women died, mirroring the broader global pattern of higher mortality, male mortality. These findings reinforce that sex, gender, and multiple morbidity are central determinants of COVID-19 outcome and highlights the need for public health policies grounded in routinely updated gender disaggregated data on contact, infections, and deaths to design equitable and effective response. In addition to my co-authors, I would like to express the sincere appreciation to the members of my supervisory committee, as well as Windreef, St. George's University, the Ministry of Health, the Government of Grenada, and CARPHA for the invaluable support in making this research possible. So on behalf of all the collaborators involved in this study, thank you, and I'm happy to take any questions that you may have.
Thank you, Ms. Belmar. Are there any questions? Please go ahead.
Yes, thank you. Thank you very much for that very good presentation. I think a lot has been said. Pandemic. Can you hear me? Okay. Right. So I think there might be opportunities for us to go beyond the comorbidities, but also start looking at the inflammatory marker. I don't know if that was part of the study, because that seems to, because what I think also happens as a consequence of COVID-19, we see increasing chronic diseases as well. And so while we speak a lot about comorbidities, I think in addition, going forward, we may now have to look and see what implications that COVID-19 may have had with respect to an increase in chronic disease because of, and that's why I'm making the point of, in these kinds of studies, it will be useful for us to look at the inflammatory marker, CRP, and so forth, because that can be a real indicator for chronic disease. And this is just a suggestion, not a question, going forward in terms of doing a longitudinal line. So thank you very much.
Thank you for your suggestion.
Any more questions in the room?
Yes, yes, please.
When looking at the data, HIV was not really a big thing. There were 1 or 2 persons that they recorded, so maybe the data of HIV was not recorded or missed. So that was one of the limitations to the study. That was data that was already there.
And Vanessa, if I may ask you, because I know that you did most of the laboratory diagnosis with the Ministry of Health team and everybody. Did you look back and see which genotype was circulating at the time when most deaths occurred? And also, did you look back at your records and see what the CT values were for those that died and those that didn't in the same age groups? Did you dissect it a little bit further? Because I think it's a great presentation that you've done. Thank you.
Thank you for that important question, Dr. McPherson. And yes, I did look back at the data. And when we had the COVID-19 death, it was the Delta variant. The most was the Delta, and then the Omicron with the waves of in 2021 in December and in 2022. So when 2022 came around, we had the Omicron variant, and 2021, December, was the Delta variant. And there were no co-infection between the 2 variants. And the CT values for the humans were very, very low. We had CT values of 11, which means that there is a high viral load. So that was the findings that we found from the human side.
Thank you very much. Let's give her a round of applause. Before I welcome the next presenter, just a reminder, there's no liquid usage allowed in the dome. We've had some spillage and the support team has reached out, so I'm just echoing that. So even if you have your bottle, please use it outside of the dome. So I now would like to call to the stage LaShawn McCloy Johnson. She's a registered nurse from the Ministry of Health Guyana, and she will be presenting an educational strategy to reduce HPV vaccine hesitancy among parents of adolescents from selected schools in Georgetown, Guyana, an experimental study. And for those following in your agenda, this is the oral presentation 86. Please go ahead.
Good morning, everyone. Thank you for this opportunity to be presenting on behalf of my research team. This morning, I'll be sharing findings from our study reducing HPV vaccine hesitancy among parents of adolescents in Georgetown, Guyana. This study focuses on a critical public health issue, one that sits at the intersection of prevention, education, and behavioral decision-making. Oh, sorry, good. Cervical cancer continues to be a major cause of morbidity and mortality among women in Guyana, even though it is preventable. HPV is the primary cause, and vaccination remains one of the most effective interventions available. However, what we are seeing is definitely not a lack of access, but rather a gap in acceptance. Vaccine uptake remains low, and this is strongly influenced by hesitancy of parents, which is shaped by misinformation, cultural beliefs, and importantly, how risk is perceived. This study aimed to evaluate the effectiveness of a structured educational intervention in reducing HPV vaccine hesitancy among parents. More specifically, we wanted to determine whether a target educational session could influence not just knowledge, but also attitude and the willingness to vaccinate. A quantitative experimental design was used, incorporating both a control group and an experimental group. A total of 58 parents participated in the study after the inclusion and exclusion criteria. Structured questionnaires were used to collect data that assess the key domains of knowledge, attitudes, perception, and willingness, measured by pre and post tests. We then applied statistical analysis, including chi-square and odds ratio, to determine whether the intervention produced meaningful changes. Ethical approval was obtained from relevant authorities prior to the intervention. In this slide, we also saw improvement in more specific areas of knowledge, such as the awareness of the link between HPV and cervical cancer, which increased by 33%, and an overall knowledge of HPV transmission reached 70%. This is important because understanding both the cause and the mode of transmission is essential in shaping preventative health behaviors. Despite all of these gains, there were significant barriers where 54% of the parents initially identified lack of knowledge as a key reason for hesitancy. However, more striking is that 60% of those parents continue to believe that their child was not or is not at risk. This finding is critical because it highlights that increasing knowledge alone does not automatically translate into behavioral changes. In attitude and willingness, we did observe improvements in attitude and willingness. There was a 21% increase in parents choosing to vaccinate their child despite having doubts. And 83% of those parents expressed confidence in effectiveness of the vaccine following the intervention. This shows us that education can positively influence decision-making, even when there are some uncertainty. The statistical analysis further reinforces the findings that nearly 5 times more, the parents are 5 times more likely to believe in its effectiveness, nearly 4 times more confident in vaccines beliefs, and more than twice as likely to be willing to vaccinate their child. Additionally, we found a statistical a significant association between the gender of the parent and willingness to vaccine. It suggests that demographic factors may also play a role in vaccine decision-making. With all of this together, these findings point to an important conclusion. Education is effective in improving knowledge and confidence, but it does not fully eliminate hesitancy. This is because decision-making is not driven by knowledge alone. It is also shaped by belief, cultural context, and critically, how individuals perceive risk. In conclusion, educational interventions are effective in improving knowledge and confidence, but addressing parental beliefs and risk perception is essential to reducing vaccine hesitancy. I would like to thank all stakeholders, collaborators, and participants who contributed to this study. Thank you very much.
Thank you very much, Ms. Johnson. We now have a moment to take a few questions from the audience. Please go ahead.
Hi, Dr. Noel here. I just wanted to ask, with the beliefs of the parents, kind of whether religious background was investigated, because we know that the message that often parents have is the concern that the HPV vaccine may increase promiscuity in the individuals. Was that looked at all, or in the message, the education?
Thank you very much for that question. Yes, what we found is that cultural beliefs were more, yes, there are future plans to have this taken. Yes, there are future plans to have this taken to other regions and so on. The reason why Georgetown was selected for this study because, well, of course, it is where we reside, and with the selection criteria for the school that we used when we obtained data from the Regional Health Services Department of the Ministry of Health, this school was the school with the lowest uptake out of 5 schools that we examined. If that answers your question.
I'll take one more question from the floor. Please go ahead.
I think the last question triggered me to ask something. Was there any consideration given in determining the target group? A section of the population that has a high prevalence of teenage pregnancy, if that was ever considered as a site, to administer such a vaccine. Thank you.
Thank you for that question. No, that was not considered, but we can use that in a future study, that consideration.
Okay, thank you so much. Let's give her a round of applause.
Thank you very much.
Our next presenter, I'm just checking if they're in the audience. Asi Lakhan, can you wave? Okay. Is there a presenter, Danraj, in the room? Okay. If not, we have come to the end of our session. Right. Let me just do one more call. You never know. Let's check. I'm asking one more time for Danraj and one last call for Asi Lakhan. All right, thank you so much. Please have a good lunch. Thank you, everyone.
Assistant Provost for Research from St. George University in Grenada. I'll be your chair for the next two feature lectures. I have the honor and privilege of introducing Professor Elsie Lefranc. Professor Lefranc is Professor Emerita at University of the West Indies. She is a social scientist with extensive experience in medical sociology. She has contributed significantly to work on health inequalities, health reforms, and health policy. Her final research focus was on interpersonal violence and aggression, where she highlighted that men are as much a victim as women, but suffer in silence. The title of her presentation that will be delivered as a video presentation is Socioeconomic Determinants of Caribbean Health in an Era of Global Uncertainty. We would be very grateful if the audiovisual team can proceed to play the video presentation that has been provided.
It is a profound honor to accept this award from the Caribbean Public Health Agency at its 70th anniversary conference in Guyana. I'm deeply grateful and genuinely humbled by this recognition. 70 years of public health leadership is not just a milestone. It is a testament to sustained commitment, regional collaboration, and an unwavering belief that the health of our people matters. In fact, as the CARICOM heads of government so poignantly recognized in its Nassau Declaration at the conference in the Bahamas that launched the Pan-Caribbean Partnership Against HIV/AIDS in July 2001, the health of the region is the wealth of the region. This mission has been an essential template for my research and provided a legacy that I shall forever cherish. I am delighted to know that the CARPHA Strategic Plan of 2025 to 2030 has placed research at the heart of its hope for advancing Caribbean health through collaboration, innovation, and sustainable action, which you so appropriately captioned Stronger Together. The elements of your strategic plan are indeed rooted in the belief that by asking better questions, collecting better data, and challenging existing assumptions, we can build healthier, stronger communities. None of my work has been done alone. In the early days, it was difficult to get the medical scientists to hear the social scientists talk about socioeconomic factors that affected health behaviors and health status. Even if we got them to agree that socioeconomic status was significant, getting them to explore and understand the how, the why, was a challenge. I would like to think that there has been a great deal of progress since that time. I must share this award with colleagues at the University of the West Indies, especially at the Institute of Social and Economic Research, where I was director for a time, and also with colleagues at the Child and Adolescent Health Department at the University of the West Indies at Mona, and the Chronic Disease Research Center in Barbados, and also at PAHO, WHO, and IDB, where we were involved in promoting guidelines for distribution of medicines globally. They included dedicated research teams, community partners, mentors, students, and health professionals who have worked alongside with me. Their insight, resilience, and passion have shaped every achievement being recognized today, and I hope that some of these colleagues are among the esteemed gathering at this celebration of CARPHA's 70th anniversary. I am sorry that I myself cannot be there. Public health researchers' research in the Caribbean carries a unique responsibility. Our region faces complex challenges such as emerging infectious diseases, chronic non-communicable conditions, climate-related health threats, health inequities, and resource constraints. But as we possess extraordinary, but we also possess extraordinary 2000s institutions and were the subject of intense various CARICOM private and public partners. And in consideration of their findings and recommendations, the Caribbean Community Heads of Governments in 2009 agreed that consolidating the 5 regional health institutions into one agency offered the most effective arrangement for the region's public health response. The process for the establishment of CARPHA was the latest round of activities that fulfill the requirements laid down in the Nassau Declaration. I recall with pride being engaged in the seminal report of the Caribbean Commission on Health and Development, 2006, chaired by Sir George Allain, and before that being involved in the discussions that triggered the Port of Spain Declaration, unifying to fight the non-communicable diseases. And before that, as co-author of the seminal Caribbean Health Study, presented to Caribbean Group for Cooperation and Economic Development at the World Bank in 1996, that foretold the need for any entity like CARPHA. Being here tonight, or being a part of the 70th anniversary conference at the Caribbean Health Agency, I feel both deeply honored and deeply reflective. Awards are often described as the recognition of excellence, but for me, this award represents something else. It represents voices that are often unheard, uncomfortable, or overlooked. In this regard, it would be remiss of me not to point out that I have not been in active research for about 10 years. The last venture that highlighted my journey into the perpetrators of physical and psychological domestic violence. As we explored the issues further, we found it useful to connect the problem to the widespread occurrence of corporal punishment